Hello to everyone in Riyadh and rest of Middle East. I've never been to Saudi Arabia, by the way. I'd love to visit one of these days, post-Corona, that is. So with that, my name is Ramesh Ayala. For those of you who don't know me, I'm here in Tampa, in South Florida. Uh, Thankfully, so far, the incidence of coronavirus has been pretty low for us here. While New York is in New Orleans, my old home is taking a big hit because of Mardi Gras and the subway that they have. So, having said that, the topic that I was asked to talk on today is how to improve your success of following glaucoma drainage devices. And so in 10 minutes, I'll try and show you some special cases and how to and techniques that might help you to improve your success rate. So successful outcomes for any surgery depends, of course, on proper indication, surgical technique, take advantage of what the eye has to offer because each individual eye may have had other surgeries in the past. Study the studying the blood is a big art in itself, and I strongly encourage all of you to do that every time you see a patient. You want to study the blood, suppression of hypertensive phase, which is well known following glaucoma, drainage devices, know how to deal with the failing blood in special cases, right? So there are a couple of implants that most commonly are used in the United States. Very few people use Maltino in the United States. I don't know about Riyadh and other parts of Saudi Arabia. But we tend to use Ahmed glaucoma valve and the Barwell glaucoma implant. The way I look at life, Ahmed, we use Ahmed for most cases, most things in life. Higher risk of hypotony, especially those with high risk of hypotony, like uveitic glaucoma, prior CPC, patients with GRA, etc. Higher risk of suprachoroidal hemorrhage, elderly, anticoagulant therapy, prior vitrectomized eyes, etc. Immediate IOP reduction is needed. So you don't want to put the Barwell implant in a patient with neovascular glaucoma where you have to tie the tube down and expect that the IOP is going to be lower. And on the other hand, I tend to use the Barwell glaucoma implant when I really want to lower the intraocular pressure down to like 10, 12 or so. Our average intraocular pressures with the Ahmed glaucoma valve are about 14, 15, somewhere in the range of 16 millimeters. With the Barwell, is about somewhere around 12, 13 millimeters or so. So that's the distinction that I use in my practice. So for most things, I go with Ahmed. When I have a person with primary open-angle glaucoma, severe optic nerve cupping, and the traps have failed, then I go to the Barwell implant. So surgical technique, dissection itself is very important. I use light OIP mixture to do the dissection of both to provide anesthesia, dissect, as is being shown in the video. Is the video coming out okay? Can you guys see the videos? Yes, okay. So, and help control bleeding. So the Lido provides the anesthesia, the EP controls the bleeding, and put together, when you balloon the conjunctiva, half of my dissection is already done. And then I go in with underwater cautery to cauterize the surgical field. And then, of course, proper placement plays a role. Proper dissection, sometimes the unexpected happens. Here is a case where at the end of the case, I realize there's a buttonhole. So what do I do? Do I sacrifice the surgery? No, of course not. So you need to know how to handle different complications that may potentially happen in the middle of surgery, because a lot of these eyes, remember, have prior surgeries done by the retina guys who like to go through conjunctiva and destroy the conjunctiva for you. And those are the areas where you're likely to undergo buttonholes. Now, here is a case where right on top of the plate, I have a large buttonhole. So what am I going to do? You can close this in two layers, right? I mean, separate out the tenons, close the tenons with a running nano-vicryl on a BV needle, and then close the conjunctiva on top of it. Now, there may be some eyes where there's not an adequate tenons. You can harvest tenons from the inferior conjunctiva, and then transplant the tenons, close it in two layers that way. And it works pretty nicely by doing that. Now, there are special situations where like in this particular patient, where patient presented with scleroderma, tight conjunctiva, and tight orbit, and the pressures were like 40 or something on maximum medications. And this, she already had CPC done in the past. The, that's her only eye. So what I'm doing here is there's no way to dissect the conjunctiva. That was the reason why the other glaucoma person sent this patient to me. What I'm doing is to do a superficial scleral dissection. And now remember, most of the times the way the conjunctiva is bound down is only to the first 4 millimeters from the limbus. So for the first 4 millimeters, if with the sharp blade, you do a superficial scleral dissection, as I'm doing here, and then jump into the into the subconjunctival space after that. Now you created yourself a nice pocket, as I'm showing. And in this kind of tight eyes, there's absolutely no need for you to put a large implant. A pediatric Hammett valve is perfect. And you know, gaining some control is better than losing all control by struggling with a big plate implant. Here I completed surgery with a pediatric Hammett valve and inserted the tube. And when I'm doing it inferiorly, by the way, I like to create a scleral flap under which I place it. It is much more elegant. You don't have this the patch graft showing through the lid, which is ugly looking. And patient's own natural sclera can be used for this purpose. And then you place this, and then you close the tube, and then the flap on top of it, and close the conjunctiva. This particular patient did very well on 2 drops. I got the pressure around 15, and she had no problem subsequently for a long time. Now, also take advantage of what the eye shows. Every time I do a Barwalt implant, I never do a Barwalt, by the way, as a primary procedure. I always do when the trab has failed. So what do I do in these situations is to open the trab. I tried all this dancing around that a lot of people do with Barwalt in terms of shutting the tube down and then creating the slit valves. They really don't work. There's no predictable model that I am aware of where you can get in the immediate postoperative period for in Barwalt and the Weichel tie is down for you to get lower pressure. So what do? I open up the previously failed trabeculectomy as part of my surgery and applied mitomycin around it. And I shut with the Weichel tie, I shut the tube down completely. And by doing that, I bought myself 2 things. I bought immediate IOP control. It takes about 6 weeks or 4 to 6 weeks for the Weichel to completely open up. Now I have a partially opening trap that's controlling the pressure in the immediate postoperative period. When the Weichel opens up, the Barwalt will start functioning. Now, occasionally you may run into a problem where both the tube and the trap are functioning, and you may have hypotony for a little while, but that's okay. You can control that by serial injections of viscoelastic till the scar tissue forms around, and eventually you will end up with perfect pressures of 10. But most cases in this kind of eyes, the trap starts failing in the 6 to 8 week period as the tube opens up, and you'll end up with good results. Now, in the postoperative period, you got to be prepared to handle unexpected. Here is a 13-year-old boy with Axenfeld Rygers with high pressures that I put a tube in. The guy comes in a week later with a flat chamber. As you can see, the tube is stuck, penetrated the capsule, and questioning, the grandmother said, yes, he's been rubbing his eye vigorously. One day post-op is doing perfect. A week later, this is how he comes in. And what do? Do I take the patient back to the operating room for this? No, I do a lot of procedures as a slit lamp. This is something that I think every glaucoma anterior segment surgeon should be comfortable with. I don't know why the video is not playing fast enough. But anyway, what I did in this particular patient is to inject a viscoelastic at the slit lamp and reform the chamber. And that way, and also during the reformation, I pull the tube away from the capsule that it's punctured. By the way, if you ever puncture the capsule in the middle of surgery, don't panic. Nothing is going to happen. The sky is not going to fall down. You will develop a localized cataract in that location, and that's about it. I've never seen these cataracts progress beyond that. And even if it does, that's one more surgery, right? I mean, anyway, at some point you got to take the lens out. And so I don't hesitate taking the lens out. I'm not so sure why the video is not playing. Okay, there. I apologize. I tested all of this out before. Okay, Anyway, I keep moving. So for what do we do for a failing blood? There's another thing that you need to know if you want to improve your success rate. So one thing that I didn't put in here is to steady the intraocular pressure. So you want to follow the patient one day after the surgery, 1 week after the surgery, somewhere between 2 and 3 weeks after the surgery. And the reason for that is not only to make sure that there's no infection in the immediate postoperative period, but also to look at the intraocular pressure and steady the blood. Steadying the blood is a great art in itself. If the blood is angry, even following trabeculectomy, if the blood is angry or flat, or is it well formed, is it avascular? Those are the questions that you want to ask yourself following a trabeculectomy operation. The same thing is true for a blood following the glaucoma drainage devices, such as the Amit valve. You want to look at the blood. The blood generally goes through three phases, as you know. The hypotensive phase, this is immediately after the surgery. As soon as you place the implant in the between 1 day and 1 week and 3 weeks, what's happening there is that a lot of blood vessels come into that area, and then they dilate to drain out the aqueous that's coming into a subphysical space where it's not supposed to be located, right? And so it takes about 7 days for the fibroblast from the limbal area to migrate around the plate. And that's the reason, one reason why one-time application at the time of surgery of mitomycin is not effective following Amit glaucoma valve or a valve implant. Because the fibroblasts are just not there as we see in the trabeculectomy operation. It takes a while for the fibroblast migration to go into that location. So the fibroblast starts encapsulating somewhere between 1 week and 1 week and 4 weeks. And once the encapsulation happens, the eye is going to go into the hypertensive phase. So the fibroblasts come into that area and they start doing what I call as, they start laying down collagen. Now, collagen is kind of funny in the sense that collagen begets more collagen on exposure to high pressure. So what you want to do is to suppress the pressure during that phase. And so when the pressure goes above 15, 16 millimeters of mercury, I start the anti-glaucoma medication. So I like to use COSAP, not to use the trade name, the dorzolamide timolol combination, whatever. You have to use an aqueous suppressant, not a prostaglandin analog. In this situation, you want to have a strong aqueous suppressant to reduce the amount of aqueous going into the blood. So somewhere between 2 and 3 weeks, watch the pressure. If the pressure is going around above 16, 17, or 18, that's the time to start the COSAP, because once the capsulation happens, then it's not going to be as effective. Now, so in spite of this, let's pretend that the pressures are high and the hypertensive phase happens, and I hope this video plays out. Again, what I do is to take these patients at the slit lamp. I tap some of the fluid out of the blood with a 30 gauge needle. And after I tap the fluid out, I inject mitomycin, small quantity of mitomycin, 0.1 cc's. One thing about mitomycin, don't vary the mitomycin for the dose, the strength, the concentration of mitomycin, because you will never know what to expect. Know your patient population. Like, for example, when I was at Tulane, majority of my patients were African Americans. The dosage of mitomycin and the time that I would apply there was different from what I'm finding out here in Tampa. In Florida, we have mostly white old people. Okay, so it's know your patient population. Find out experimentally what works for you, for your patients, before you start doing this kind of procedures. And the slit lamp, at the slit lamp, what you want to do is to tap some of the fluid out, and then inject. I generally inject 0.1 cc, so a little less than that, of 0.4 milligram per cc concentration mitomycin on a weekly basis for these hypertensive bloods. And you will see over a period of following 3 or 4 injections, you will see that the blood vasculature changes. And at that point, a back off. And a lot of times between that and having a COSAP on top of that, it gives me good results. So become comfortable with doing slit lamp procedures. For everything, you don't need to panic and take these patients back to the operating room. It increases the cost of your care, and also the patients become averse to having glaucoma surgeries. Now, in spite of everything,
can we conclude, Dr. Ramesh?
Yes, ma'am.
Yeah, can we conclude, please?
Yeah, I'm
Yeah.
almost done.
Yeah.
So
Okay.
in spite of this, if you still have problems, then there's some special situations that you come across. Here is a patient with the Ahmed valve with hypotony. What you want to do is a little paracentesis on top of it, pull the tube out of the AC, tie it down with the Vicryl, and then slip it back into the AC, and then close the paracentesis with a Tenon nylon suture, and you're done. Then the pressure goes up. This is the same technique that you can use for hypotony following Barwell implant. And how about uveitic patients? For uveitic patients, use a pediatric Ahmed valve along with intravitreal canalog injection. That works very well. For JRA, same thing, pediatric Ahmed valve with the pediatric and intravitreal canalog injection works great. Neovascular glaucoma is another thing best treated with Ahmed glaucoma valve, not with the Barwell. Inject Helon into the AC to prevent bleeding, and routinely inject intravitreal canal Avastin injection at the same time. And if there is a cataract, go ahead and take the cataract out at the same time, and then do a sulcus implant so you don't disturb the blood vessels in the angle, and that way you can improve the post-op success rate. So know how to handle special situations, know how to do procedures, and be meticulous in your surgical techniques, and I think you will have much better success rate. Thank you.
Thank you so much, Dr. Ayala. We have a comment here from Dr. Karim Tami from Lebanon, and he said that he has stopped cutting the conjunctiva flesh with the limbus, and he's always leaving a 3 to 4 millimeter stump to facilitate the suturing. Dr. Randy Craven already answered that, and he said he will do that if the conjunctiva is healthy and thick. Do you have any comment on that?
So yeah, I'm aware of the technique. So here is the issue with that technique. Okay, where some people do the conjunctival dissection a few millimeters away from the limbus, like 3 millimeters in this case, or 6 millimeters away. Some people do it. The only problem with that is if this operation fails and you have to go back and redo the dissection, you will more than likely end up with a buttonhole along that incision site. That's the reason why I don't like that technique.
And what do you prefer to cover the tube? Just to decrease the chance of exposure.
I use sclera.
Sclera, always.
Yeah,
okay,
always
and we have another question. How soon would you interfere if there is a small conjunctival erosion post-operatively, and would doxycycline work?
I am a surgeon. I don't play around with these things.
Okay.
Okay, I go do some kind of a surgical procedure, either at the slit lamp or in the operating room.
Thank you so much, Dr. Ayala.
Thank you.
Please just stop sharing. Thank you, appreciate it. Can you just stop sharing your presentation, please?
Yeah, I'm actually logging out. Thank you all.
Thank you so much. I appreciate it. Thank you, Doc. Next we are having Dr. Shakil Sharif, the second speaker. He's going to speak about tube shunts in adults. Dr. Sharif is a professor and director of glaucoma service at Case Western University, Cleveland, and he is a senior instructor of intraoperative gonioscopy, a key to angle surgery. This is a very important course at American Academy of Ophthalmology that everyone should attend. And he's also the ASCR Skill Transfer Lab instructor. Dr. Sharif, please.
I'd like to thank Dr. Ohoud and the planning committee for inviting me today. I just wanted to present a case about tube management spanning the postoperative period. Let me see if I can, how I advance this here. Okay. So this is a surgical referral that was sent to me of a 68-year-old white male who basically had a pressure as high as 39 on no meds, and he's basically a very active outdoor sportsman. He was on a combined therapy as well as a prostaglandin, and his anterior segment examination was pertinent for an afferent pupillary defect and thin pachymetry. He was known also to have pseudoexfoliation in the left eye. His fundus examination revealed a total cupping, and his visual field showed significant loss with superior inferior arcuates. And because of its outdoor activities, I wasn't comfortable considering a trabeculectomy, so we offered him a combined cataract and tube shunt. This is what it looked like on post-op day 8, and if you look carefully here, you can see that there is an irregular corneal light reflex indicative of corneal edema and elevated pressure. There's a large clot in the anterior chamber and a tube. He does not have diabetes or any history of neovascular glaucoma. It's a routine, uncomplicated surgery. And you can see here there is a column of blood that's present, and despite the surgery, his vision was poor and his pressure was elevated. A bit of a massage didn't really seem to help the situation. So at this point, the question comes up, how would you like to proceed? And when we're dealing with a 1 week post-op patient with blood in the tube, we need to think about a clot buster. And so I thought about using tissue plasminogen activator. And very briefly, in terms of biochemistry, the TPA is a naturally occurring protease that in its unbound form systemically has a very short T half-life. But when it binds to the actual clot, in this case, in this illustration here, the fibrinolytic activity can last beyond 7 hours. And that'll come later in the talk as to why it's important. And what that means to me is that it has a localized effect to the site of the thrombus formation. So it really is a big plus in terms of patient safety. It activates plasminogen to plasmin that results in a breakdown products, and that gives rise to the fibrin degradation products here. In terms of the actual use of TPA in the eye, it's nice because you can avoid an intraoperative need for additional surgery. Is no reported corneal toxicity when it's less than 25 micrograms. It can restore the flow through the tube, and again, the localized effect is a big plus in terms of avoiding systemic bleeding. This is a paper by Alan Zalta, which is an important one, the largest in the series of 620 eyes, the majority of which were the, as we're talking here, about the AMID valve glaucoma drainage implants. In this total number of eyes, they found 36 of them.
I'm
Yes.
sorry, Dr. Sharif, I'm afraid that your presentation is not visible to all the attendees.
Okay, I see it in front of me. Can the panel see it? Because I can see it.
Yeah, the panelists can see, but not the attendees.
So maybe you got to share it somehow with the.
Oh, I thought I shared it.
Yes, they can see it now. Thank you. You can go ahead.
Oh, okay. So I apologize. Let me go back to, yes. I'm sorry. Yeah. So the study by Zalta showed that out of 620 eyes, those tubes that had a imminent or total occlusion with the fibrin or blood, the 36 of them, by injecting a dose of as small as 15.0 micrograms, they were able to achieve a 90% success rate in terms of reestablishing flow through the tube. And majority required just a single dose, but some of them required 2 or more doses. The drop in pressure was significant in terms of 21 millimeters of mercury, and the mean interval to the first TPA injection was about 4 days. The complications were about 10% related to hypotony and hyphema. In terms of the diagnoses, the majority of them had either neovascular inflammatory glaucoma, and the source of the tube occlusion was felt to be either the fibrin through the altered blood aqueous barrier or rubeosis. Now, this is the from the paper Alan Zalta had indicated he would simply inject the TPA to the side port incision and let it diffuse into the anterior chamber to get to the source. I prefer the technique that I've been using, where I'll make an incision 180 degrees away from the tube, and then I'll just cause some egress to cause a relative hypotony. And via that same incision, I'll insert a fresh 27 gauge needle and cannulate the tube directly and inject the TPA. And the idea and the goal is to enhance the localized effect of the TPA by injecting it directly to the clot site. And so here's our patient on post-op day 8 after injection. You can see diffuse red blood cells floating in the anterior chamber, a little bit of raised area here. Again, a very low dose that's safe. And we followed him up the next day. And despite the clearing of the tube, his pressure still remained elevated with poor vision. And careful assessment indicated there was a clot in the distal aspect of the tube. So I gave him a second low dose of 12.5 micrograms to see what would happen. 4 days later, when he came, there's a better clearing again. However, the vision was still poor and the pressure was elevated. And so on gonioscopy, I could see there's a little bit of blood where the tube entered into the chamber. There was a focally raised bleb, and I wasn't too happy about this, so I gave him the highest dose I could of 25 micrograms to see what would happen. So at one day post-op from there, or day 14, now the pressure shot up to 44. That really made me uncomfortable. So at this point, I said, I'm really concerned at 2 weeks. The pressure is not coming down, and several TP injections, 50 micrograms, didn't test this guy. So we need to evaluate this patient for a possible mechanical valve failure. I took him to the OR, and basically I did an exploratory surgery where I like using two bites through the cornea to provide a nice introduction of the eye. And basically what I'm going to do here is I'm going to inject with some lidocaine epinephrine to create some local analgesia. And the objective here really is to unroof the patch graft and to evaluate the tube by explanting it out of the eye, and to inject it with balanced saline solution. If I get resistance to trying to flush the tube, then I know that there's a mechanical failure, and there may be a possible need for a glaucoma drainage implant exchange. So we will see what here. I'm going to unroof the tube here, and I'm pulling it out. Notice that there's this long column of blood in the tube. Here's a clear part that was in the anterior chamber, which we couldn't see at the slit lamp. But look at this here. This seems to be the culprit as to why this surgery is not working, which is otherwise uneventful. And so what I try to do here is first squeegee out the blood away from the valve mechanism, so I don't want to destroy the valves. And once I take it out, this is going to hopefully enable me to evaluate, and here's the blood here, evaluate the functionality of this device. I'll inject with balanced saline solution here in a second, and you can see that when I do this, little to no resistance with good flow through the tube. And then you can see also with the Q-tip here, we're almost finishing here now, with the Q-tip, a good uptake of the fluid. And I'll inject also with Trypan Blue. I got no resistance whatsoever. So I decided, you know what, it's good to just to take this tube and reinsert it back into the chamber, and let's see how this patient does at the slit lamp. And this is basically what I'm doing here. And I'm going to repatch the tube here and put it back in the anterior chamber. I'm comfortable that I think this plate is working. And I just took the patient and finished the surgery. And what you'll see here is that just on 1 day after removal of the clot, the vision improved to 20/50 with pressure of 5. And look at this beautiful diffuse bleb here. That really made me very happy. When I saw the patient back almost 7.5 weeks later, we're close to 2 months now since the initial operation, the vision improved to almost 20/20, a pressure of 18, and a nice corneal light reflex that made the patient very happy. And you can see that there's a raised functioning bleb here, and that this provided a good outcome for this patient. He was able to go on his hiking and skiing trip. And so the purpose of my presentation today really was, in summary here, to show how you manage the tube or shunt surgery where there's elevated pressure postoperatively spanning the whole period from day 1 to about a month out. In the first 1 to 3 days, if it's a flat or raised bleb and the pressure is elevated, you have to think that there may be a viscoelastic issue here, and you can actually treat with aqueous suppressants, or you can buy time by tapping the anterior chamber or a massage. If it's beyond 3 days when the viscoelastic is washed out and the bleb is still flat, you want to make sure that it was not because of the failure to prime the valve. If that was the case, then you need to cannulate the lumen with a 27 gauge needle and flush it, either in your office setting or in the operating room. If it's beyond 3 to 5 days and you see heme in the anterior chamber or fibrin, then I would recommend a TPA injection directly into the tube lumen. You might need more than 1 injection. If it's at 2 weeks and the bleb is flat, you might need to consider mechanical valve failure and do an exploratory operation and try to flush the tube and consider a glaucoma drainage implant exchange. And finally, at 3 to 4 weeks, if the bleb is raised and the pressure is elevated, then clearly, as per Dr. Simon Law's paper, this is bleb encapsulation, and I'll start treating the eye with to initiate aqueous suppressant. So hopefully this provides a algorithm as to how to take care of these patients for postoperative tube management. And I'd like to thank the organizers for inviting me today.
Thank you so much, Dr. Sharif. We have a question here about the use of streptokinase in these situations.
I'll open up to the panel. I don't have any experience with streptokinase.
So anyone from the panelists can answer this? And the other question, there is one of the NTD has a concern about implementing or considering this technique in the phakic eye.
I don't see a problem if you have this, if you use a pupillary constrictor like a myocall to do it. Again, it's a matter of having space to do it. I think it's a relatively safe procedure.
So any comments regarding streptokinase from the panelists? Dr. Sharif, can you stop sharing, please?
Yeah, I'm trying to get off this. Yeah, I don't know how to. I think. Okay, thank you.
Okay, that's good. So next we are having Dr. Malik Kahouk. He's a professor of ophthalmology and Slater Family Indowit Chair in Ophthalmology at University of Colorado School of Medicine, Denver. And he's a Vice Chair of Translational Research and Chief of Glaucoma Service and Co-Director of the Glaucoma Fellowship at the UC Health Sue Ashworth Rutgers Eye Center. And he's the guy behind Kahouk dual blade. Today, he's not going to speak about Kahouk blade, but he's going to share his experience about tube extension in drainage devices. Dr. Kahouk, please go ahead.
Thank you. Can you see my screen that was shared with you or not quite yet?
Not yet.
Okay, let's try and do that again. It's saying that it's being shared with you. Maybe you're not seeing it though. I might actually have to dial back in to get in. Hang on 1 second. All right, let me know if you have it now.
Yes.
All right, you can see my screen okay?
Yeah, here you go.
All right, so I'm sorry for the technical problems. It seems like each Zoom meeting that I do has a slightly different setting that I need to do on my computer. Great couple of talks, and I'm looking forward to sharing a couple of cases from the University of Colorado with you. The title is Tube Extension Techniques with Glaucoma Drainage Devices. But really what I'm going to do is share a couple of different cases and see what kind of learning we can get out of it. These are my disclosures. So the first case is going to be, both of these are actually fellow cases. The first case is an interesting one that was just recently presented at one of our journal clubs with subsequent case discussions. And then the next one is a case that was done about 2 years ago by one of our former fellows that required tube extension. So the first case is a 61-year-old male with history of left eye CRVO. This was in 2019. Pressure was elevated to 34 millimeters of mercury at the time of first examination when they presented to us. Patient also had NVI, NVA. Avastin injection was done. And subsequent to that, unfortunately, the patient was lost to follow-up. The patient then returned in early 2020, left eye pain, pressure was 35, again with NVI, NVA, and 270 degrees of angle, zipped closed. The patient underwent a second Avastin injection, was on maximal tolerated medical therapy and Dimox, and planned for phaco Owaidhah valve to the left eye. Just some brief case details. There was poor dilation, posterior synechia. The patient required a Mel-Eugen ring. The iris was floppy. The bevel initially was cut short on the Owaidhah valve. And initially the first cut was done slightly sideways, followed by trying to fix that by doing a bevel down because this was going to be placed in the sulcus, which resulted in a shorter and shorter tube, as you can imagine. At the end of the case, the surgeons left a small amount of viscoelastic behind because the iris kept prolapsing each time they tried to irrigate the BSS out of the anterior chamber. So a little bit of a complex case, This was done by our fellow and one of our team members at the county hospital. Post-op day 1, the patient came in, pressure is 45, AC was deep, there was a clot supratemporally, infratemporally, and they restarted Diamox and all drops. The pressure decreased prior to the patient going home, came back post-op day 3 with a pressure of 40, and the pupil was dilated to take a look at the tube. And this is what we see here in the picture. So left-hand side, you can see a little bit of a clot. You can see the tube kind of peeking from underneath the iris. A little bit more of a zoomed in picture. And what you probably can't appreciate as much on the picture here is that the tube somehow found its way between the anterior capsule and the intraocular lens. And the tube itself was actually sequestered away from the aqueous. So there was actually no drainage that was happening. You couldn't do this unless you really tried, I think. And if you tried to do this again, you probably couldn't get it in exactly the same position. So they took the patient back to a procedure room, did a YAG capsulotomy. Post-YAG capsulotomy, you can see here on the right-hand side, the splitting of the capsule. Pressure immediately went down. Pressure was 6 after the laser and was 12 millimeters of mercury post-op day 1. So this was an example that I wanted to show about how an imperfect tube cut, tube placement, all of these things can cause less than ideal placement of the tube. But sulcus tube placement is desirable. Whenever we can put it in the sulcus and the patient's pseudophakic, we try to do that. But proper placement requires the tube not to be in the visual axis, so it can't be too long, can't be too short, because we still want to be able to visualize it and make sure that it's in the right position. And what we advocate for is always not just visualize, but also inspect the tube that's in the sulcus. You can just take a Sinskey hook and just play with the tip of the tube to make sure that it's in the right place. Now, I want to talk about some techniques for tube extension because it kind of follows this case of maybe having an imperfect length of the tube. There are multiple different ways to do it. You can do it with an angiocatheter, 22 gauge. It's bulky, 0.9 millimeters outer diameter. You can do it with a Crawford tube. Has a 0.64 millimeter outer diameter, which is very similar to what we have with the Barvelt, Ahmed, Clarepath, Multino, all of the devices. There's one tube extender that I know of on the market. It's the New World Medical tube extender, bulky. It has a height of over 1 millimeter and a width of over 3 millimeters. So it can be quite bulky when putting it in place. You can also trim another tube if you don't have access to a tube, but that can be quite expensive because you're opening up another device. Wanted to show you a case here, and I want you to pay close attention. This is one of our fellows from 2 years ago. She is one of the best surgeons that I've ever trained. She's doing the procedure, going very, very well here. And I'll try and point out a part here and pause it, if at all possible, when the money shot happens here. So she's going into trim, bevel down. And the bevel down is to put it in the sulcus. And I think I'm just going to pause it there. Hopefully everybody that's watching, a bunch of panelists, I can see Randy there shaking his head knowingly about what's about to happen. But take a look at what happens here. So she trims the tube, everything looks great, and then goes to put the 23 gauge pilot incision, if you will, comes out. I like how the panelists, I can see all of you smiling here about what's about to happen. And then she's kind of nudging it, and guess what? As she's nudging it, half the tube comes away. So if you go back to the original point of when things happened, I'll try and replay that really quick. One thing you don't want to do when you're doing this is open your scissors up too much and not really pay attention to where the distal part of the scissors is, because it's underneath your thigh forceps here. Essentially what she did is 2 cuts, right? The second cut wasn't really seen because it was covered by the thigh forceps. So you have to be really careful about that. So what they eventually did was they got out the tube extender, figured out the tube extender was a little bit too bulky. They did trim, try to put it in place, but I think we've all experienced this with the tube extender. I actually don't use this device because of the height and the width. It's just a little bit too much for how anteriorly it's commonly placed. So just to fast forward a little bit, what they eventually did was they took an angiocath 22 gauge. I haven't done this technique in a handful of years. I'll show you a technique that I do typically. But this is a nice way if you're in a bind. Get a 22 gauge angiocath, has about a 0.9 millimeter outer diameter, You can put it in place, and you don't want to put this part into the eye, of course. You want to just use it for extension of the tube. You can use tenoproline to go through the tubes to connect them to each other. You do the same thing on the other side, and I'll just fast forward here a little bit just for time's sake. And then after you put this and secure it, you basically just bevel the tube, put it into place, and you can call it a day. Now, again, great surgeon. She does a great job with her surgeries, but some of these things happen. So it's really good to know what to do in that circumstance, and there are multiple options. Now, this is the technique that I've been using more recently, there's a nice reason why you should do this, but let me just give you an overview. Essentially, the tube extender with an angiocath, the TE device from New World Medical, or some of the other Crawford tubes that you can purchase are not really necessary if you just save your tube when you trim the initial tube. Always have it on the Mayo stand ready to go, because you never know what might happen for tube extension. If you do have a short tube, you can take a remaining portion of the tube and do what you see here in the middle panel marked B. You can put tie forceps into the tube, extend it, so spread it apart, which is what you're seeing in the video on the bottom left-hand side, and then you can feed the trim tube into the spread out tube. This is what's called an interference friction fit. It works really well. It works with a standard tube, works with a Crawford tube. And it's a nice way to do this at not a lot of expense, because most of the time you have the remaining tube sitting right there. So just one pearl to take from this discussion. Now, some closing thoughts. Always visualize and inspect the tube at the end of the case. I always take a Sinskey hook and just make sure that we're ensuring placement is right. Save the trim portion of the tube until the case is over. Don't dispose it. Tell the nurse, the scrub tech, not to dispose the tube to make sure that it's handy. And then tube and tube techniques is effective and most closely resembles the biocompatibility and also the fit, the geometry of a standard tube. And I think it's something you consider if you're not doing it. And hopefully that's another pearl that you can take with you into practice right away. I'd like to thank Dr. Seibold, Dr. Capetina-Young, Dr. Ertel for providing these cases. And I'm happy to answer any questions.
Thank you so much, Dr. Malik. There's a comment from Dr. Samir Ahmed. He's just suggesting why not to use a new implant or a new tube rather than doing the tube expander in these situations.
Yeah, so the problem with that is a couple of problems. Typically when you're in this place, the plate has been fastened to the sclera already. You're through most of the surgery and you're basically right at the finish line, and it's much easier to grab the trim portion of the tube and extend it at that point. You can certainly grab something from the shelf and put a new Barvelt, new ClearPath, Ahmed, and whatever device that you're using. That's certainly an option. But now you have to go through the point of taking it off the sclera, cutting the sutures, disposing the device, and putting a new one in. It's actually much faster just to extend the tube with some of these techniques.
Okay. Thank you so much, Dr. Malik.
Yep.
Next speaker is Dr. Davinder Grover. He's the attending surgeon and clinician at Glaucoma Associates of Texas, and he's the director of research at Glaucoma Associates of Texas as well. And Dr. Grover also has a Master of Public Health degree at the Harvard University School of Public Health. He's gonna speak about how to repair complex tube erosions. Dr. Grover, please.
All right. Well, can you all hear me okay?
Yep.
Perfect. All right. Well, it's always hard to follow Malik. Nice job on that presentation. And Dr. Hood, thank you for organizing this and for allowing me to participate in this great opportunity just to have this collegial exchange, making the best of some tough situations right now. First thing I'm going to talk about is complex tube erosions, and I'll do my best to stay on time. These are my disclosures, none of which I think are pertinent to today. Just before we start, thoughts on masks. I'm not sure if this movie is one of my favorite childhood movies, but who knew that the Dread Pirate Roberts was going to be able to predict the future about all of us wearing masks these days. So hope you all are being safe and taking care of yourselves during this craziness. I want to start off with just a case presentation. It's a 63-year-old female with a history of diabetes, hypothyroidism, and hypertension. She has a history of eye syndrome in her left eye. She's undergone multiple surgeries, including a corneal transplant, cataract surgery, trabeculectomy, and an Ahmed valve. She comes in with an erosion in her left eye. She's on combined brimonidine timolol as well as FML for her transplant. Her right eye, thankfully, as we see with ICE, is normal, but in her left eye, she's light perception, pressure 17. She has extensively scarred conjunctiva, but her PK looks good, thankfully. And you can see, she's pretty advanced glaucoma, extensive loss of nerve fiber layer on OCT. And this is what she looks like. And you can see here's the old trab site. She has extensively scarred conj, and this little black area, it's a little mascara. And so what are the options we have? So we can, attempt a direct closure, maybe use a conj autograft. I think that's the thing I don't like of all the options, because you're basically taking conjunctiva and cutting off all the blood supply, which is what you really need in these kind of situations, and I'll go into that later. You can cover it with cornea, sclera, pericardium, whatever one you think is best, and hope that epithelializes over. You can do something more invasive, which is repositioning the tube. You could remove the tube entirely and do some ciliary ablative procedure, or you can remove the tube entirely and put a tube down in the infranasal quadrant. And what we're going to do is pause a little bit and talk about flaps, skin flaps. So, the purpose of a skin flap in general surgery is to recruit healthy tissue with a healthy, intact vascular supply to an area that's been deprived of vasculature. And when you're designing the flap, you need to make sure that the width of the flap it's about a 3-to-1 ratio, 3 in length to 1 in base, to make sure that you have adequate supply to the distal part of the flap. And you don't want to have any tension. You really want to have it nice and relaxed. So I'm going to introduce some terms called the interpolated pedicle flap. So interpolated means that the base of the flap is not adjacent to the site where it's going. And a pedicle flap means you're going over some healthy tissue. And the importance of that is to, again, I think a big component of tube erosions, in addition to the positioning of the tube and tunneling, is adequate vascular supply to the tissue. I don't think you ever see a tube erosion when you have wonderfully healthy, thick conjunctiva. It's almost always when it's the scarred, atrophic conjunctiva. And we do flaps in ophthalmology with Gunderson flaps and Hughes flaps. But again, the goal is to bring healthy vascularized material. And I think it's much superior to these autografts where you're cutting off all the vascular supply and bringing tissue on. You've basically shot yourself in the foot. So here's a picture of this patient that an artist did for us, where we isolate the tube and we put a piece of corneal tissue over it. You need to kill all the epithelial tissue, otherwise it won't heal appropriately with cautery or alcohol. And then I put a patch graft over it. Then I double evert the lid, and one of my colleagues, an oculoplastic colleagues, basically double everts the lid, gets the forniceal conjunctiva, not the tarsal conj, but the fornix. You go to the fornix, you cut out some tenons, and you rotate that whole tissue. And you can actually pass a cyclodialysis spatula under here, because it's not a scar, it's a flap, and there's no scar tissue over that, and it's not healing, and there's no tension on it. So let's see what that looks like. And the oculoplastic surgeon that really helped us here was Jim Merritt. So here's this patient. She has that area of mascara. You can see extensively scarred conjunctiva. Really, there's nothing you can do to this conjunctiva at all. So what I'm doing is I'm first creating a pocket around it. And in retrospect, I think now what I do actually is I'll dissect it more and take the tube out and reposition it. I think that's also nice, because this is a pretty anteriorly placed tube. So I like to secure the tube to the sclera. And then this is a piece of partial thickness corneal tissue that I'm going to tuck in the pocket and secure with some Vicryl sutures. And then suture that in place. And once it's secure, then I turn it over to my colleague, who's an oculoplastic surgeon, does things that I never thought could be done for the eye, which is, put some big, thick sutures through the tarsus and double evert the lid. And he's just marking that 3-to-1 ratio, and he's injecting some lido with epi for hemostasis. And then he's just going to take a partial thickness piece of that and create a flap with some tenons. And he's done this so much that he doesn't need to really measure out. But it's nice to keep that 3-to-1 ratio, which is really a mantra in flap creation and general surgery, and make sure it's long enough to be able to be transferred over to the target site without any tension or any effort. So you can see it's really loosely flapped over there. And then and you don't need to suture much except right here at the limbus and maybe right here at the base, but you don't suture under this at all. And what we're doing is providing healthy, vascularized, thick tissue to an area that's been chronically deprived of that. It's not a symblepharon. You're not creating a symblepharon. It's really, there's a lot of laxity. And again, like I said, you can pass a cyclodialysis spatula underneath the base of that because it never heals. So this is what she looked like on post-operative day 1. And this is, you can see some healthy vascularized tissue. This is what she looks like on post-op month 1. And again, you can pass a spatula or something underneath here. There's no tension, no risk of double vision or anything like that. And then, 5 years out now, her pressure is still controlled. She still has limited vision in that eye. That she has no evidence of an erosion. It's her left eye. You can see even externally, it doesn't look like anything was done. But you can see this nice bed of healthy vascularized tissue 5 years later. And again, you can still see this area has not healed. It's not a symblepharon. There's no tension on the globe because we've made it nice and lax. And 5 years out, you see this almost this oasis of blood vessels in this desert of avascular conjunctiva. And these are the eyes we do this in. These are eyes that have had multiple prior surgeries, ischemic, thin, frail conj. There's no other way to repair this. And if you look in the literature of all evidence for tube erosions and repair, the recurrence rate is almost 50% when you're doing some type of autografts or other things like that. We do some extensive, I know in Saudi, you guys take care of a lot of tough eyes and tight orbits, and we do the same thing here. And sometimes you need to actually incise the lid to have access to the fornix. And any self-respecting oculoplastic surgeon can put a lid back together without any problems. And again, here's some evidence, this just desert of avascular conjunctiva with this nice oasis of vessels that we've incorporated into it, a recipe to ensure that you're not going to get a repeat erosion. And this guy had his lid split. He has a PK and ACIOL, and you can really just split the lid, access the fornix, bring that conjunctiva over. And again, the dimensions are vital. You'd really need to have adequate, proper dimensions of 3-to-1. I do this in conjunction with an oculoplastics colleague. We reported this technique in 2013. And the average follow-up in this paper, we're still following these patients, and they're still doing well. We have not seen a single repeat erosion in any of these eyes, but in the case studies, it was almost 50 months. And a third of these patients had diabetes, which is a risk factor for erosion. And 80% of these patients had 4 or greater prior ocular surgeries, tubes, trabs, PKs, everything. So, tubes are becoming more common throughout the world with more cost-effective tubes available, like the Owaidhah implant. And because the more tubes we're doing, we're going to see more complications. Tube erosions are extremely challenging, and I think using this interpolated pedicle flap is a safe way and effective way to incorporate healthy vascularized conjunctiva to an area. So thank you for your time, and I'll take any questions.
Thank you so much, Dr. Groover. And we have a few questions here. Have you encountered any ptosis or limitation of down gaze with this procedure?
No, and that's because the design of the flap. Again, you need to make the flap appropriate. You're taking it from the conjunctival fornix, so there's no tension on that tissue. And you're not at risk of any kind of double vision. If you take it from the bulbar conjunctiva or the tarsal conj, then you could probably be at risk for that. But when you take it from a nice, healthy, if you see the fornix, you only see it by double everting the lid. It's just healthy, loose bed of conjunctiva. You can, as long as you have an appropriate size and rotate it, you don't see that complication at all.
And would this flap be appropriate for the body of the valve, or you just use it for the tube?
You know, I think the first maneuver you need to do is you need to get rid of all the epithelial tissue. It's much easier to do that when you have a tube erosion, because then you can destroy all the epithelium, cauterize anterior to the tube, under the tube. When the valve gets involved, that steps up the level of complication. Because in a valve, it's very hard to get rid of all those epithelial cells that will just grow all over and in the valve. So I would say when you have a plate that's exposed, I would say you need to take out the plate and replace it with a new plate and destroy all the epithelial tissue in that area. Then if you have no other quadrant, then I think it'd be reasonable to put another plate in there, close it up, tie it off permanently. You know, you don't want to put, if you do, you don't want a valved implant because you don't want flow because the integrity is not going to be that great. You want to tie it off permanently, maybe with tie it off with a 7/0 proline with a 4/0 nylon ripcord tucked inferior. Tie it off so it will not open. Put the tube in place, get the tissue over there, close it, wait for a month or actually 2 months, 3 months until you know all that tissue is healed, and then you can open it up. But the big thing you're doing, especially with these tube erosions, is you need to make sure you destroy all the epithelial tissue in the whole area. And I think it's very hard when it's in the plate.
Okay, beautiful. Thank you so much, Dr. Groover. If you can just stop sharing, please.
Done. All right.
Okay, great. So now we'll just move to the British school and British experience. We have Dr. Keith Barton here with us today. He's a consultant ophthalmologist and a glaucoma specialist at Moorfields Eye Hospital in London. And he's an honorary leader in UCL Institute of Ophthalmology. And he's the co-chair of Ophthalmology Futures Forums and editor-in-chief of the British Journal of Ophthalmology. Dr. Barton is going to speak about cyclodialysis cleft repair. Dr. Barton, please. Can you unmute, please?
I can't share at the moment.
You can now, sorry.
Okay.
Yep.
Okay, I think I'm on. Can you see me?
Yes.
Can you see the slides more importantly?
Yes, Doc.
Well, this is off the wall by the standards of what we've dealt with so far. But, you know, I discovered early on as a glaucoma specialist, because we cause hypotony, people tend to send us other things that have hypotony as well as just glaucoma. And therefore, we see occasionally traumatic hypotony from cyclodialysis clefts. Just trying to get the slides to move. The case I'm showing you here is one of many that I've seen, but this is one from about 9 years ago. This 15-year-old boy from Athens with a 3-month history of reduced vision and hypotony in the right eye after a motorcycle accident. I'm not sure why a 15-year-old boy was on a motorcycle, but that's a different thing. He was diagnosed as having a deep cyclodialysis cleft and had 3 courses of argon laser with no improvement, followed by cryo with inflammation and no improvement, persistent low pressures and choroidal folds. On examination, his vision was reduced to 660, 624 with pinhole. The other eye was fine, 6.4 unaided. Pressure of 4 in the right eye compared with 15 in the other eye. Macular folds, shallow chamber, no useful view of the angle. And this is the affected eye. You can see the chamber shallow. And this is the unaffected eye. And I think you can just about see from this the chamber significantly deeper. On gonioscopy, as is typical with soft eyes, you don't see any angle at all. And where's the cleft? You can get an impression by angling the gonioscope, but overall you don't see very much. My standard approach in these cases is to be absolutely certain where the cleft is, how many of them there are, and the exact dimensions. And I find without deepening the chamber in some way or other, you really can't do that. No imaging is just about as useless as gonioscopy. The chamber's shallow and the cleft's closed. So 0.2 mil of Provis to the anterior chamber of the slit lamp, followed by gonioscopy again, and you can see all is revealed. You can see there's a fairly large cleft there with a few little septa in between, but basically there's your problem. So that was quite a large one. It's had 4 failed conservative attempts at closure. So direct cyclopexy seems to be the only option. And this is one of the very few clefts out of the 40 odd I've done that I never videoed. But so you've got a very interesting diagram here, which is probably going to be completely take about 30 minutes to work out. But basically, traction sutures in the tenons, a large scleral flap, traction sutures in the cornea to get good exposure, large thickness scleral flap. And he actually had 3 clefts, 3 individual separate clefts, visualized, sutured the ciliary body back on Owaidhah nylon, closed the flap, and postoperatively, he did remarkably well. He presented with a pressure 5 days later, the pressure was between 19 and 20. 14 days later, pressure is 22. This is, to be honest, a miracle. It's an unusual postoperative course because they either have a hypotony for a few weeks afterwards till the cleft closes, or they end up with a pressure of 100 if you get it successfully closed. And this guy didn't get a pressure spike and didn't get hypotony afterwards. So he was a very lucky young guy. You can see because of the extent of the surgery, there's a lot of sutures. The pupil's a little eccentric, as they sometimes are if you don't get the anatomy just right on closure. This was just a few days later. You can see there is some bare sclera, so I have recessed the angle a bit inadvertently, but the cleft's closed. 3 months later, pressure's 14, no glaucoma medications. He's a really lucky guy. This was so smooth. Visual acuity 612, which is a miracle given the history, but he's got a bit of cataract. And you can see you can still see the big ugly sutures where the cleft was closed. The pupil actually isn't very eccentric. It looks okay, although it's semi-dilated there. You can see a little bit of choroid showing through at the wound. But overall, I think this is quite a good result for this guy. And in my experience, you need to avoid cataract surgery for as long as possible in case you blow the cleft back open with the fluid turnover. So blunt trauma causes shockwave in the cornea and a shockwave in the aqueous, and that pushes the iris and ciliary muscle backwards, and various expansion rings in the eye wall outwards. And obviously there are 3 possible results: angle recession, iridodialysis, or a cyclodialysis cleft where the actual ciliary body separates from the scleral spur. And to fix these can require quite invasive surgery. There are many reports of simpler ways of treatment, but it is worth remembering that about 99% of these heal spontaneously. And the ones that don't are the ones that conservative treatment generally doesn't work for. In my experience, accurate localization is essential. An accurate determination of the extent and number of clefts is essential. There have been many reports of imaging assisting closure, but in my experience, imaging really doesn't cut it, because it's very difficult to determine the length, extent, and number of clefts with imaging if the eye is soft, like that guy. And slit lamp viscoelastic deepens the chamber, opens the angle, and allows good gonioscopic visualization, like here. But again, even with imaging, it's very difficult to determine the extent. Here's another one from a few years ago. Without viscoelastic, you can't really see anything. With viscoelastic, you've got a few air bubbles, but you can clearly see the cleft. And this is my kind of go-to slit lamp diagnostic test for diagnosing clefts. And if you can't see them, you can't fix them. And this is the young guy. Iridodialysis is an important differential, but pretty much always iridodialysis isn't seen in combination with clefts. But very occasionally it is, such as this one here. The circle's just off slightly, but there's a tiny cleft there. And again, with imaging, you'd pick up the iridodialysis, but you wouldn't see the cleft. So The other problem with imaging that I find is that at Moorfields, if you send someone to the ultrasonographer with hypotony asking for if there's a cleft, the answer is always yes. And most of the time that's not true. So surgical management, if you're going to go and operate, you need precise localization, and you really need to know what you're doing. Now, cryo is useful for small clefts. And this guy already had cryo, so I didn't repeat it, but this is a short talk, so I can't go through cryo again, but I basically don't use all the described, laser, Botox, ginkgo, capsular tension rings, vitrectomy with gas, oil, herbal tea, rejuvenation creams, or anything other than cryo or surgery, because while there are many, many reported conservative treatments, 99% of clefts heal spontaneously, which explains most of the success of conservative treatments. And the ones that come to me are generally ones that have been sitting around for 2 or 3 months and nothing's worked. And then actually you really need to get proper apposition and close the thing surgically. So I do wait until at least 6 weeks after the surgery, because in general, they've been there that long before they get to me. If you get them earlier, I can understand why it's entirely appropriate to use something like laser. But you've got to remember that if laser works 1 week after surgery, there's always the question, well, the cleft probably would have closed anyway. So direct suturing is fun. You've got to make a full thickness scleral flap about 3 millimeters from the limbus and stitch the ciliary body or choroid or whatever back onto sclera. Needs good access in the correct location over the whole length of the cleft and for all the clefts that are present. And you see, some are larger than others. You can see how the ciliary body bands clearly differentiated from iris here. You can see it's a different color basically. And as I say, you need to be able to see everything. Why? So that's why you even make big flaps for small clefts, because even with a small cleft, you don't often the adjacent ciliary body can be weak and poorly attached and come off later. So this is overkill for this cleft, and probably cryo might have done. But you can see as I was suturing there, more of the ciliary body started to detach and the cleft got bigger. And this is a risk, especially with phaco later, that it can blow off again. Opening up gives you good visualization of their structures. Here you can see the long ciliary nerves. This is the only time I've seen the anatomy with such clarity. But that cleft was behind a PAS, which you can see right in the middle of it. And sometimes, as in here, you can see the surrounding, again, the surrounding tissue is weak and starts to fall off as you open up. So in other words, if you haven't got total apposition, it may detach later. Here's one where a moderate sized cleft's divided in the middle, almost looking like 2 clefts. So why close them with big, horrible, ugly sutures? Well, because if the IOP goes up afterwards, the wound can basically explode. And I've seen this twice, and not for a long time, but this was the first one that I did in 1998 with Roger Hitchings holding my hand. And a few days later, the pressure went through the roof and the whole thing dehissed because I'd used Tenon nylon. In the videos I've just shown, I've used 8-0 nylon. I don't think 8-0 is essential. I tend to use 9-0 now as a reasonable compromise. But you do need large sutures. But how can you avoid this kind of barbed wire under the conjunctiva? Well, you can make a superficial frill. You can make a larger flap than you need and make a superficial frill and bury the sutures under it. And this avoids the barbed wire. And this technique takes longer, and you need decently thick sclera, but it does produce a nicer cosmetic result. Then you've got to suture the ciliary body band, which is sometimes very clearly visible. Other times it can look just like you're suturing the choroid, which is fun and makes you feel like some kind of commando and a real hero. But the strange thing is, despite the number of these I've done, I've never yet had a significant bleed from the choroid, which is interesting. And you've got to close it all around so that you get a bulge and test for leakage so that you don't have drainage afterwards. It's okay to have a little tiny bit of drainage afterwards, because remember, it probably will heal. But I have been caught out and I have occasionally revised them. And you can see the flap here down at the bottom has been extended because it didn't quite get all of the cleft the first time. So once you've sutured it up, you can glue down the flap, because remember the flap, the superficial flap's not the tension bearing, but the 9-0 sutures are underneath that. And you can use tissue glue to glue that down. And you can see how much more of a nice cosmetic result that is than the original super ugly sutures that I used. It still has the ugly sutures, but they're underneath. And then you can glue the conjunctiva. And I think you'll all agree that that's a better looking result. You can see again a slightly eccentric pupil, and you've got to be really careful with the big ones to try and get the apposition bang on. Otherwise, you do end up with slightly peaked or slightly eccentric pupils. So most clefts recover with medical therapy and don't need surgery. Cryo is actually quite good for small clefts if you have a department where there still is a cryo. I use a triple freeze thaw, and I haven't showed it here because we don't really have time. There are many reports of less invasive laser techniques and so forth, but very little evidence of equivalent efficacy. And certainly early cleft techniques will seem to work simply because they'll close anyway. And there's a couple of papers we've done. We've also recently done a multi-center retrospective study with Ike Ahmed in clinical experimental ophthalmology. And thank you very much for your attention. And that's it.
Thank you so much, Dr. Barton. Very interesting case. So how would you deal with the IOP spikes post-operatively? We know that most of those patients, they go for very high IOP the day after the surgery. Luckily, your patient didn't have that situation. Yeah. So yeah. Do you hit the patient with ECP, for example?
No, the problem isn't often the day after. If it happens the day after the surgery, you can deal with it because you can do a paracentesis right there and then. The patient's there, you can give them Diamox. If it goes very high the day after the surgery, sometimes it's because you haven't taken enough of the viscoelastic out. And it is important really to take the visco out. The problem is when it goes up 2 weeks later and the patient lives 100 miles away. That's more the problem. And then they need to get in. And they do, the first one I did, I remember talking to Peng Kaw, he said, yeah, the pressure will be 100 tomorrow. It actually wasn't, but the problem is it happens whenever you're not there. If it's high when the patient's in the office, you can do a paracentesis and you can get the patient to hang around and repeat the paracentesis. And usually you're talking about patients who have not had pre-existing glaucoma. The trabecular meshwork isn't functioning because it's been bypassed for a while and it suddenly has to start working again. And very often they do get back to normal pressures without glaucoma meds. But to start with, you've got to manage the spike. And in my experience, it's Diamox and paracentesis and topical medication. I've rarely resorted to surgery. I have done a tube in perhaps 1 or 2 in the longer term, but that's been rare.
Okay, great. And is there any rule of CTR in those cases? Have you ever used them in those?
No, I think that I really can't see how that would work. The only logic behind it is I've heard it describe CTR in the drainage angle, and I really don't want a piece of plastic rattling around in the drainage angle. So if you put a CTR in the capsule in a pseudophakic patient and it takes tension off the ciliary body, well, that's a possible theoretical explanation, but to my mind, you know, you need to ensure opposition and the only way to be sure of that is to see what you're doing and fix it.
Yeah, Dr. Shakil, do you want to comment on that?
Yeah, we have a very large series that's published with Ike Ahmed, looking at five international centers, and
yeah, I was an author.
Yes, as you know, it's a very good in my hands. Is, you know, again, we have to remember these are anecdotal and these are very few cases. Yeah. Unfortunately, we don't see them often. But for me, it makes sense if you assess the white to white and you put the appropriate capsular tension ring in and align the eyelid, and you align the eyelid to the actual cleft in the sulcus. In my handful of patients, they're done very well.
Oh, good.
It takes away the guessing game of where we have to identify the extent of the cleft, especially if there are multiple clefts. It takes away the guessing game because it covers a whole 360-degree.
Are your CTRs large enough to actually compress the ciliary body?
I think you have to look at the case-by-case basis, but if you reinforce the cleft with the eyelid in the axis of the cleft, I think that really helps.
How does that reinforce it? Because it'd be the springiness of the ring that would close the cleft, not the position of the eyelid, surely.
Yeah, but if you're suturing the eyelid, 2 millimeters back
so you're suturing the eyelid
to the sclera in the axis of the cleft, you're basically killing it. There's no unless a guy's got chronic hypotony due to ciliary body shutdown. But again, these are a handful of cases. But it is definitely an option to consider.
This is the problem. I mean, many of the cases, even in that report, many of the cases were very soon after the original cleft, and they would have healed spontaneously anyway. So you don't really know what the efficacy was.
Yeah, I mean, definitely, we were trying to look at an ab internal approach. Obviously, if someone's got a cleft that's 180 degrees, that means for a very large area to operate in, it really can be very challenging from an ab external approach.
Yeah. Okay, thank you so much, Dr. Barton, again. Now we'll just go back to Dr. Davinder Grover, and he's going to speak about risky of failing blip. Dr. Grover. Dr. Barton, can you stop sharing, please? Thank you.
Right.
Yeah, if I can figure out.
Yeah.
Okay. Keith, very nice talk. So I'm going to try to do our best to keep us on time and move forward with the next talk, which is ab internal bleb revision, rescuing a failed bleb. My disclosures haven't changed, but let's start off with a case scenario. So this is a 47-year-old male of European descent who presents with a long-standing history of glaucoma, diagnosed in his 20s. He's on essentially max medications in his left eye and has had a bad reaction to a prostaglandin. Comes to see me in May of 2012 with a pressure of 26 in his left eye and a pretty cupped out nerve. The right eye is pretty healthy. On exam, he has a Krukenberg spindle, 4+ transillumination defects, and extensively pigmented angle on gonioscopy and a mild NS. You can see the asymmetric nature of this glaucoma affecting his left eye. He's not the best visual field taker, but I think a lot of this is real, especially when you look at his optic nerves, and you can see that his left optic nerve is pretty significantly damaged. So we have a 47-year-old male with uncontrolled advanced pigmentary glaucoma. So what are our options? We have, we can add oral meds. I don't like to this is a young guy who has hopefully 40, 50 years of life left. Want to get him off as many drops as possible. Don't want to add more medications. I do not think SLT is appropriate in this situation. I think that an argument can be made for almost every other surgery, maybe not canaloplasty and trabectome, but for almost everything else on this list, trab, tube, deep sclerectomy, whatever you feel most comfortable in your hands. What I did with this gentleman is I did a trabeculectomy. This was back in 2012. I was not injecting mitomycin. I was still using sponges at that time. So I used 0.4 for 5 minutes. And he was doing well, thankfully. And he had a nice controlled pressure and a low diffuse bleb. And the right eye was doing well. And we were just trucking right along. Everything was great. And then he comes in, I'm following him regularly, in April of 2015, so almost 3 years later. And he's getting a pretty significant PSC. He still has a nice bleb. His pressure creeped up a little bit. I put him on latanoprost, but still has a decent looking bleb. And so we moved forward with the cataract surgery in his left eye. In the recovery room, I gave him Diamox and I gave him some Timolol in the eye to anticipate a pressure spike afterwards. And the first day after surgery, he kind of had a low bleb. His pressure spiked up to 30. And I tried to massage it a little bit, got a little bit of an elevation. I put him back on max medications. And 1 month later, his pressures were still high, pretty much had a flat bleb. I could not get it to elevate at all. And his pressure was 25 on max meds, which is not what we don't like. So again, same options are on the table, except now you can consider a blood needling. But what I want to introduce is something we presented and described back in 2017, which is an ab internal blood revision. And we designed a spatula, which is a sclerostomy spatula, to help us accomplish this task, which is kind of a nice curved spatula with a blunted tip, a thinned blunted tip with a blunt edge, and then the sides are a little bit sharp to allow for cutting. What you do is you make an paracentesis down at 6 o'clock. You come across the anterior chamber, you put Helon in the eye. I use a traction suture here. You need to be able to see the ostomy on gonioscopy because you want to go into that ostomy. You got to flip your brain upside down to get in there, and then you come off with the gonioprism. And then the blue nature, and I didn't design this, that was Mateen Amin with Epsilon that picked the color blue to help us see it better. And what you can see with this is a couple things. One, you're just unroofing the posterior aspect of the flap. So you're getting that diffuse posterior bleb. It's not, you're not getting this peripheral bleb at all. You're just getting that diffuse posterior bleb. Number two, you're going through the flap. And anybody that's ever taken down the conjunctiva and seen a scarred trabeculectomy flap, you see that that fibrotic tissue is mostly avascular. So as opposed to needling from the slit lamp where you're going through vascularized tissue and you're at risk of breaking a blood vessel, you're going through this avascular tissue. You're selectively controlling, opening up only the posterior component, and you get this low diffuse posterior bleb, and you really want to get a far dissection as possible. So let's look at a video. And here's a case. You can see the bleb over here. I don't use a traction suture in this case. I make a paracentesis down below and a paracentesis in the superior temporal quadrant. Put in some Helon, and then that's the higher view of the spatula. And I go across the anterior chamber, put the gonioprism on the eye, and you want to be able to look, you got to flip your brain upside down. It takes a little practice at first. But you want to look down at the inferior angle or inferior mirror to see the superior angle. Get into that ostomy and then stay there and then come off. And in this situation, I use my 0.12s to rotate the globe down. The next video I'll show is one where I use the traction suture. There's almost 2 barriers of scar tissue, which is crazy. The first ring of steel that we see, and then there's usually a second ring that you won't see unless this is about an 18mm long curved spatula that helps you break down all those layers of scar tissue and really get far posterior into the fornix. And just selectively opening up that posterior flap, and you can get pretty rough with it and really get far posterior as possible. You're going to get hypotony on the first day, so you leave some Helon in the eye. I put atropine on the eye, but these are patients that have already presented themselves as having a propensity for scar tissue formation because they've already scarred on their bleb the first time. So I think I have a lower concern. So I'm right now for a scar tissue formation or of hypotony, I'm sorry. What I do here, you can see that nice bleb up top. I take out all the Helon as much as I can. I think some of that Helon goes in the subconjunctival space, which I think helps to make it keep that bleb functioning. And let's look at one more surgery. This is an unedited video. Let me just move it along. Here I use a traction suture to rotate the globe down. And again, you got it on the exam lane. You need to look on gonioscopy and make sure you can see the sclerotomy site. It doesn't come up here, but it's right that well. However, if you can't see the sclerotomy site, you can't do this surgery. And if you can't see it on gonioscopy in the clinic, then you should not try to go see it in the operating room. Here's some Helon in the eye. The patient has prior RK, you can see, which makes it a little bit more difficult. And I think I'm frozen. Hold on. Okay. And now here I've already gone on gonioscopy, got into the sclerotomy site. Then I use my traction suture to rotate the globe down. And again, you can see the blue color of the spatula. It will help you visualize where you are. You want to selectively just open up the posterior aspect of the flap. and it's blunt on the tip. So you're at a much lower risk of conjunctival buttonhole. And I've done this initially with a cyclodialysis spatula, and that is puts you at very high risk for a buttonhole because it's such a pointy, sharp one. It's also short, and it doesn't let you get far, far, far back. But you really want to just get as far posterior. You can see that bleb forming right away, and you don't be shy. You really want to move it and get a nice dissection through both the layers of the scar tissue. You come back out, and here, what's nice is here, now you can see the sclerotomy site. That's not following up on Keith's talk, that's not a cyclodialysis, but thankfully that's the sclerotomy site that you can now see. I like to suture the wounds anytime I do anything like this, especially with a patient with prior RK. You are at risk of some hypotony. I leave some Helon in the eye, but then you look at that nice diffuse posterior bleb. You have complete control, as opposed to in the slit lamp, you have complete control over the formation of the anterior chamber and control over it. And so back to our patient, he had that flat bleb on June 8th. I planned for an ab-internal bleb revision. I gave him some mito on postoperative day 1. The pressure was 10. He had a diffuse bleb, and this is actually his picture from postoperative day 1. See that nice diffuse posterior bleb. Post-op month 3, I started tapering it, and he had a nice thing. And actually, I saw him back in December, post-op year 4. Left eye pressure still 11. He has that nice diffuse posterior bleb, and this is what he looked like. And this is what they look like beforehand, and this is what they look like after. You see this, really the blebs that we all dream about, which is this low diffuse posterior bleb afterwards. So when do I do it? I do it in patients with a scarred flat bleb, a Tenon cyst that can't be needled at the slit lamp. I want to avoid doing a trab on a tube on a patient, or in a patient that has a bleb that fails after phaco, like in this situation. Now I inject mito far posterior to where I know I'm going to be directing aqueous once I open up the flap. I do that at the beginning of the case. And we reported our outcomes back in 2017 in the Journal of Glaucoma, showing a significant drop in pressure and sustained IOP control. And in the 21 eyes we did this in, only 4 of them had to go on to have further a tube shunt. So we've saved 17 eyes from having another incisional aggressive surgery. I leave Helon in the eye. I put atropine on the eye, give the patient a Kenalog subtenon's Kenalog injection. I'm aggressive with my steroid use and atropines and keep them on limited activity. This is not like a new technique. Dick Simmons back in the 90s described this. What he was doing was going through the cornea and using a cyclodialysis spatula, and he did not use mitomycin C. I think using the spatula that's curved and 18 millimeters long it gives you a much more predictable diffuse dissection that's a little safer. You're going through avascular tissue, which makes it less likely to bleed. You must use mitomycin C to augment this, and I think it's a more controlled method than doing it at the slit lamp. This is the instrument. It was Mateen Amin with Epsilon helped me design this. I have no financial interest in that at all, but he does donate some of the sales to our foundation. So thank you all for your time.
Thank you so much, Dr. Gruber. Actually, this is my preferred technique for bleb needling if the patient is also planned for cataract or phaco. But usually I don't use mitomycin, but I can see that you use mitomycin immediately prior to the surgery. True?
Yes, I do. I do it at the, I used to do it in the clinic. So when I consented a patient for the surgery, I would inject a dilution of mitomycin C and lidocaine in the quadrant where I thought I was going to direct flow at the slit lamp. And then a week or 2 later, I would take them to the operating room and just open it up. Now we're getting a lot more comfortable just injecting mitomycin C in the operating room. So at the beginning of the case, I'll inject, I have my patients blocked, and I'll inject the smallest amount of mitomycin C possible, the highest concentration. So if I did 40, I would do 0.1 or 0.4 mito, which makes it 40 micrograms, and I'll inject it in the far posterior fornix where I know I'll be directing my flow. And by the time I inflate the eye and I'm doing the whole procedure, after I think the mito, after about 5 or 10 minutes, is pretty much bound, and I think it's safe. I keep the pressure in the anterior chamber high, so fluid is always leaving through the flap and further diluting that mitomycin C, which I think further improves the safety in case you're concerned about mitomycin C refluxing into the anterior chamber.
Yeah. Okay, great. Thank you so much, Dr. Gruber. Okay, we'll just move now to the next speaker. We have with us Dr. Brandy Craven. He's the Associate Professor at Johns Hopkins University School of Medicine at Baltimore. And he was the ex-chair of glaucoma division at KCASH. He used to be my boss. And he's one of the first US surgeons to implant many new mixed devices like iStent and CyPass. Dr. Craven is going to speak about Zen implantation tips. Dr. Craven, please go ahead.
Thanks, Ohoud. And let's see if I can share my screen here. All right. Yeah, having the same problem Malik did. Give me 1 second. All right.
So I think Dr. Craven just logged out and he's trying to sign in again. So meanwhile, any questions or any comments from the panelists?
Hi, Devinder. I just wanted to ask you a very interesting technique, and I saw a few internal revisions when I did my fellowship in Canada a few years ago. And long term, I was really impressed with the diffuse posterior blebs. But the scary thing I noticed was the hypotony on day one, which you alluded to.
Yeah.
And Paul Rayfuse, who was the surgeon that I was with at the time, I don't think he used to use viscoelastic in the eye. But have you encountered any cases of like severe, scary hypotony first day post-op?
No, because I leave a lot of halon in the anterior chamber because you created this really almost an unguarded filter in the far posterior. But these patients have a propensity for scar tissue formation because they are very scarred once. So if you leave adequate amount of halon in the anterior chamber, and I think there is some thought that getting halon in the subconjunctival space will also prevent scar tissue. But we've been doing this now for about almost 8 years. And have not had a case of persistent hypotony. What I do is, if I think I'm worried about hypotony and it's a couple weeks out, then I'll taper the steroids pretty quickly to maybe induce some scarring. But no, what protects you initially in the first couple of days and the first week is leaving some halon in the anterior chamber.
Right, thank you very much.
All right, thanks. Sorry for the IT glitch. My screen is sharing fine with everyone? Good, great. All right, so just as Devinder pointed out, we're all in search of that perfect bleb, which is, as he described it, low, diffuse, posterior. And there's been many systems trying to grade those. And with the Tenon's capsule, we really struggled over the years trying to figure out, what to do with it while we're doing our glaucoma surgeries. And this was a great paper done by Kakazaki, where they took a look at the anatomy of the Tenon's capsule. And if you look at it, the Tenon's capsule really starts about 1.5 millimeters back behind the cornea, and it intertwines really much with just the substance of the conjunctiva, and it's very, if you will, external from the sclera where it's located. So when we're trying to deal with Tenon's capsule, people have tried different techniques. Years ago, Lerner thought if he could go underneath the Tenon's capsule by how he created his trabeculectomy, you might avoid fibrosis with that. And many people have tried different things. We've tried cutting it out. This was a series done by our Egyptian colleagues where they took a look at pediatric trabeculectomies. They found that a tenectomy seemed to help better survivability of the trabeculectomy if we use that. And certainly with valve implants, Jeff Friedman and others have looked at whether or not we might want to place the valves above the tenons rather than under the tenons and end up with better success rates. Jeff Friedman has spent a lot of time looking at this with his Maltino implants. And the Zen implant, I think, has a lot of trouble with what goes on with the tenons. To me, the Ab interno approach, and as you can see from the red arrow there, when we exit the eye and how it gets through the Tenon's capsule and underneath the conjunctiva, it's not always so easy. And I'll show you some pictures and images of that in a minute. But it's really a problem that we have with the Ab interno technique. Now, the Ab externo technique, to me, allows us to try to avoid where the Tenon's inserts and get away from the tenons if at all possible. So what I've started to do is to use a technique where we make a very small incision just on the cornea and then stay just above the tenons as we carefully dissect right there, and then use a cyclodialysis or iris spatula to just go ahead and make a pocket. So I haven't disrupted the tenons at all. I've stayed away from it 100%. Go ahead and put my mitomycin in, and then put the Zen in Ab externo through this, deliver it, and then after it's placed, you can adjust the position or the length of it by pushing it in or out of the eye. You can slide it in a little bit and slide it into that pocket right above the tenons. And then through doing that, you don't have it tangled up in the tenons at all. The closure is really pretty straightforward. I tend to use a little double loop, which I taught all the fellows at KCASH on the conj, and then bury the knot. You get a nice watertight closure. And I've found through doing this super tenons technique, my needling rate out of the last 60 I've reviewed is 0, which I've been very happy with. And they end up with these blebs, just like Devender described, which is a very posterior low diffuse bleb. And that's because you're totally staying away from the tenon. So I found that that has a huge advantage for me as far as how I do with those and not having to do all the needlings. So I found the other advantage of the Ab externo technique is you can go to almost any quadrant, end up with a posterior bleb, you don't have erosions. And the IOP, I've been doing it now for about 9 months, but I've seen some of the 9 months out, their pressures are 8 or 9. That's off of medication. So I've been very happy with the IOP success. Now, why is this a technique that I would consider over the other ones? You know, I did, Juan Kim, who's near me here in Bethesda, Maryland, he likes to do the trans-conj technique, where he basically uses the needle to go through the conjunctiva and then puts it into the anterior chamber. Now, the problem I've had with that, it's all related to the eye rotation and the angle of approach and the ability to create what you want through doing it this way. So here you can see a trans-conj, and to get the needle flat enough so you can keep the implant laying on the sclera and not bending up to where it can get an erosion, it's not easy when you do the trans-conj technique. The Ab interno technique, similarly, I think it's sometimes harder to get the placement where you want it to be. You know, it's obviously made for nasal technique and works great in older Caucasians that have real mobile, thin tenons, and you can get it right subconj, especially if you inject a little bit of air. So you can do it if you're doing somebody like that, the nasal technique, that method. But the things I've found with it is that sometimes, even if I've done it the Ab interno technique, I have to open the conjunctiva. And there's those that I either plan it or I don't plan it. And usually when it's not planned, it's because it's a corrective action because of what happens to the implant within the Tenon's capsule or the episcleral tissue as it gets tangled up in that. Then sometimes I'll plan to go ahead and go ob internal if I'm placing it nasal, and then open the conj on purpose to allow me to go ahead and put mitomycin in or whatever I'm planning on else doing at the time. So here's a typical picture of somebody I had to convert. So here you can see this is an ob interno. It comes out and does that candy cane thing where it bends like that as it gets tangled up in the tenons. And that was despite our best efforts. So we had air under the conjunctiva, which you can probably see back over here. And it still didn't allow us to get the implant where we wanted. So this is somebody we had to open the conjunctiva and then do a corrective action. The other thing I've seen is that sometimes when we're doing this, you'll end up with this track in the episcleral tissue, and the tube itself of the Zen is kind of caught in that tissue as you've gone ob interno. Then you have to open that up, free it up, and then that allows you to be able to put it where you want. So for me, the thing I've been doing is rather than have to get into doing all this, I'll just go straight to the ob external technique. But the other thing I wanted to point out with the Zen implants is the angle of approach and what you have to do when you're trying to put it in. And there's too steep and there's too flat of approaches, and they lead to different problems. The too steep of approaches usually ends up to where the implant lays nice and flat on the sclera as it goes back posteriorly, but it can get tangled up in the episcleral tissue if you're coming ob interno. And if it's too flat of approach, then the nub of the Zen sticks out there, and that's where you get the erosions with those. So consider the angle of approach. And for me, I think the best way to do it really is to go with the ob externo technique and say super tenons. And I've found great success with this lately. I mean, this is by far my favorite surgery right now for using for most patients, whether they've had valves in or failed deep sclerectomies or whatever. I think it's a utility player that I like a lot. All right. That's all I have on that. So I'll quit sharing the screen there.
Oh, thank you so much, Dr. Craven. Well, actually, I don't have too much experience with the Zen, but I would love to know what's your exact protocol of the mitomycin you're using, the dose and where to give exactly and yeah.
I'll use somewhere between 40 to 60 micrograms, depending upon the eye, and inject it into the pocket, just as Dr. Grover kind of described with what he's doing with the bleb needling. Very similar approach to that.
Okay, thank you. Any other comments from the panelists? Okay, thank you, Dr. Craven. Now we'll just move to the next presentation. We have our good friend, Dr. Ahmed Arif. Dr. Arif is the Associate Professor of Ophthalmology with Tenon at Illinois Eye and Ear Infirmary at Chicago, and he's the Director of Glaucoma Fellowship and also Residency Program. And he's the lead editor of Glaucoma section of EyeNet Journal and EyeWiki Encyclopedia website. Dr. Arif is going to speak about glaucoma in keratoprosthesis. Very interesting topic. Dr. Arif, please go ahead.
Thank you very much. How's the screen look there?
Perfect.
Okay. Well, thank you for having me. You know, this is really an innovative conference. Thank you for your monumental efforts in putting this together. I can only imagine, you know, how much work this took from an IT perspective and also from your personal time. So thank you.
Thank you.
Talk today about a challenging situation, I think, for us as glaucoma specialists managing glaucoma in the setting of keratoprosthesis. I'll show our approach to managing this problem of many approaches and hope to learn from the panelists and the audience as well. These are my disclosures, none of which are really relevant to the subject matter here. And the Boston keratoprosthesis is really made of three parts: a front part, which is a PMMA optic, and then a back plate, which is made out of either PMMA or sometimes titanium. Sandwiched in between those is a corneal graft. And that corneal graft is sutured to the patient's native cornea, and the whole thing gets locked together with a locking ring and that allows for clearing of the optical media in the treatment of causes of corneal blindness. And it's really an innovative device that's allowed many patients to regain meaningful vision in cases where they were not able to do so before this device became available. There are many problems, though, as we've learned with keratoprosthesis devices. The first of which, and most importantly, I think, is glaucoma. And if the patient doesn't have pre-existing glaucoma, they will most likely be dealing with a glaucoma problem over their lifetime after implantation of this device. And that's because the device is so bulky and it's pro-inflammatory in nature. These images come from a study that was performed at our center where you can see that over time, patients develop progressive synechial angle closure, which is the primary cause of glaucoma in these patients. Virtually all patients will undergo this series of events. It's just a matter of time. This is our approach for dealing with the problem at the Illinois Eye and Ear Infirmary. It's a team approach where we tackle the problem head on. At the time of keratoprosthesis implantation, we perform glaucoma filtering surgery with a tube shunt that's directed into the pars plana. Typically with these cases, the glaucoma surgeon starts the case by creating a conjunctival peritomy. And as usual, doing some dissection here in the supratemporal quadrant. We typically go with the Beervelt 350 millimeter squared implant, tucking the wings of the implant under the respective extraocular muscles and suturing the implant plate to the sclera, just as typical for our usual cases. Now, at this point in the procedure, the glaucoma surgeon will tuck the tube under the implant plate and take just a little bit of a breather, letting the corneal surgeon and the vitrectomy surgeon take over. Here, the corneal surgeon comes in next and removes the diseased cornea and places a temporary keratoprosthesis, mostly so that the vitrectomy surgeon can adequately view and do their work, do a 3-port pars plana vitrectomy, and of course, if we're planning to insert the tube into the posterior segment, important to shave the vitreous base. Here, we've measured anterior to the ora serrata and entering the posterior segment with a 23 gauge needle parallel to the iris plane. You can see the needle tip here across the pupillary axis. If we want, we can confirm placement, safe placement of that needle using binocular indirect ophthalmoscopy. You can see we've got that 1 millimeter safety zone anterior to the ora serrata with the needle placement. So it does help to have a vitreoretinal surgeon by your side as you do these procedures to allow for the most posteriorly possible placement of the tube while of course maintaining that safety margin. The tube has been ligated here, trimmed, and then we'll place the tube into the posterior segment through that entry site here. And then at this point, take a little bit of a break again. Once the tube has been placed into the posterior segment, corneal surgeon's gonna take over here, release that temporary keratoprosthesis, and now the previously assembled Boston keratoprosthesis will get sutured into place using multiple Tenon nylon sutures. Glaucoma surgeon then takes over. This is actually the patient's original cornea. The original diseased cornea that we're gonna cut to size and use as a patch graft here to decrease risk of postoperative erosion, and then suture our conjunctiva. Here we're using 7.0 Vicryl. So that's our typical approach. These are of course going to be longer procedures. The idea is to tackle these problems head on because it's much easier to deal with glaucoma surgery at the time of keratoprosthesis implantation than it is afterwards. Bandage contact lens here is placed to allow for hydration of the ocular surface. So I do wish that all cases went as smoothly as what I just showed. The reality is they often do not, and this is a case that will illustrate that. This is a 62-year-old African-American male who had a history of a remote chemical injury in each eye, history of secondary glaucoma, unfortunately lost all meaningful vision in the right eye. This is the better seeing left eye. You can see an opacified cornea there, vision of hand motion. The patient had pre-existing glaucoma and had previously undergone diode laser cyclophotocoagulation. In spite of that, his intraocular pressure was about 20, which we deemed to be too high for the long term in this patient who we are planning keratoprosthesis implantation. Plan here was to do just as what I had shown, keratoprosthesis implantation, along with a glaucoma tube shunt and pars plana vitrectomy. So here's surgical footage from that case. The glaucoma surgeon starts the case, injecting lidocaine with epinephrine into the subconjunctival space, placing our Beervelt glaucoma implant, tucking the wings under the extraocular muscles, as was shown. And then once the plate has been sutured, tucking the tube under the implant plate and reserving it for use later on in the case. Here, corneal surgeon removes the diseased cornea. We get our first look into the anterior chamber, and things actually don't look too bad inside. This patient was phakic, so we went ahead and performed extracapsular cataract surgery to leave the patient aphakic afterwards. Here are the vitrectomy surgeons taking over. 3-port pars plana vitrectomy, very important when doing these posterior tube shunts to shave the vitreous base and really explicitly direct the vitreoretinal surgeon to do so. Here we're entering the posterior segment with the 23 gauge needle. Again, you can see the needle tip through the pupillary axis. And now we're getting ready to place the tube within the newly created sclerostomy and into the posterior segment. No resistance here that we're getting. We had previously visualized the needle cross the visual axis, so we don't expect any surprises there. Trying to get a look at the tube within the posterior segment, and really I'm having trouble visualizing it. So I give my vitreoretinal surgeon a nudge and try to get him involved here, make him earn that big paycheck. You can see he's performing some good scleral depression for us here, trying to visualize the tube. We're expecting that maybe it's curled up somewhere and expecting it to show itself. Unfortunately, despite some good effort by my vitreoretinal colleague, we're having trouble visualizing the tube. What we do see is just posterior to the ciliary processes here, a little bulge deep to the retinal interface and deep to the choroid. So that tells us that likely the tube has not entered the posterior segment, but rather it somehow found its way into the suprachoroidal space. Fortunately, we've noted that intraoperatively, we go ahead and take the tube out of the suprachoroidal space. That's not where we want to be. And try again after raising the bottle height, firming the eye up a little bit, entering again with the 23 gauge needle into the posterior segment, and give this another try here. Place the tube within that tract, and here we can see the tube within the pupillary axis, fortunately. So I think the key here is making sure and ensuring that you visualize the tube in the posterior segment before moving on to your closure. Otherwise, there can be big problems later on. This patient, we followed out to 7 years. This patient we see every 3 months with the cornea service and the glaucoma service and the retina service, not necessarily on the same day. So this patient puts in a lot of work and understands that preoperatively that this is going to require a lot of work on their end to achieve a good outcome. Fortunately and amazingly, vision has remained 20/20 and intraocular pressure has remained controlled. So these are just, this is our way of dealing with the problem at the infirmary. Thank you. And thanks again for allowing me to be here.
Thank you so much, Dr. Arif. Very nice videos and presentations. We have a question from Dr. Samir Ahmed here from Washington. He's asking, why not to use a smaller implant like 250, as long as you don't have a hypotony in those cases? And he's also asking about what's the rate of hypotony if you have any.
Yeah, thank you. Great question. You know, interestingly, and this is a question we deal with a lot, you know, whether it's a smaller implant or considering a valved implant. And basically what it comes down to is, you know, once you do these procedures, this patient is going to need lifelong glaucoma care. And as anybody who's tried to provide postoperative care for patients with keratoprosthesis, it can be very difficult to tell whether glaucoma is progressing. It's impossible to accurately tell what the intraocular pressure is. It's hard to judge visual field progression. It may be hard to visualize progressive optic nerve deterioration, particularly if the patient has advanced cupping to begin with. And for that reason, I like to be aggressive from the outset with the most aggressive and most telltale and predictive way to get the pressure down into the low teens as we need for these patients, and also get the patient off medications because their corneal disease may complicate matters if you're treating with topical medicine. So for that reason, I like to go with the sure thing, in our case, a Beervelt 350 implant. And then in terms of hypotony, often these patients are younger because it's typical underlying causes are aniridia or chemical burn injuries. And so they scar quite aggressively over valved implants. And for that reason, we go with non-valved and larger implants, because we're usually dealing with higher pressures, and hypotony is less of a concern. Of course, it's always a balance for us as glaucoma surgeons.
Yeah, thank you so much. You remember when you had visited the KCASH last time, we had a discussion regarding our, few cases we had to use the UCP in keratoprosthesis. So maybe Dr. Chardil would like to comment on that.
Yeah, nice talk, Ahmed, as always, as we talk. Well, basically, the good news for us is that the IRB have affected our research, and probably in the following months, Dr. Dania Bameflet and myself, we will be able to have the full results. So far, treating those patients with hypertonic eyes or early stage glaucoma with 8 sectors of UCP, it seems that the pressure seems getting under control, at least in the first 1 year that we have followed those patients. Of course, we have been working together with the anterior segment department on Dr. Vargas' supervision. And well, it seems that is also a chance. I'm totally agree with your talk that if the patient has a real glaucoma, advanced glaucoma, and you really have to get a lower pressure, the option is what you have done.
Yeah.
Thank you very much. Yeah, looking forward to those results.
We'll see how it goes.
We all do. Thank you so much. Okay, next we'll just move to the next presentation. We'll go back to Dr. Davender Grover. Thanks for your generosity, Dr. Grover, for giving 3 presentations. He's going to speak about gonioscopy-assisted translaminal trabeculotomy, GAT procedure.
All right. Well, thank you. I can't share my screen. I think, Ahmad, nice job, but I think you have to stop sharing your screen.
Oh, okay. Yeah,
yeah, Dr. Arif, please.
Sure.
This has been great. It's so nice to see the high quality of presentations and see everybody's face. Again, Dr. Wood, thank you for making this happen.
Thank you so much.
It's really a great way to make the most of these tough situations. Okay, so last talk is going to be on GAT, and what I'm going to do is just do a brief introduction of what GAT is, and then talk about a case, then do some basic videos and how I do it. So, trabeculotomy is not a new concept. It's been around since the 60s, if not longer. And initially it was done ab externo, and Redmond Smith was one of the great thinkers of trabeculotomy. And this is how he did it ab externo, doing some cut downs, passing the suture, cut down, passing the suture. And why a trabeculotomy? Morton Grant really showed in one of the landmark studies that 75% of the resistance to outflow was in the trabecular meshwork. David Epstein redid those studies and showed it was about 2/3, but regardless of the number, we know the vast majority of resistance to outflow in glaucoma and the average glaucoma patient is through the trabecular meshwork. So we came up with a technique called the GAT procedure, which is gonioscopy-assisted transluminal trabeculotomy. And the same artist that helped with our initial illustration, she helped us with this, where you, within the eye, cannulate the canal with a suture or catheter, pass it around 360 and retrieve the distal end. You can do this with a $4 5-0-Prolene suture. So you cannulate the canal, you can see the back wall of Schlemm's canal. This is the MVR blade, and then you pass the blunted tip of the 5-0-Prolene suture around. You retrieve the distal end and externalize it, and just through 2 small paracenteses, you have a 360 trabeculotomy. So this was a woman, a 55-year-old woman of European descent with no past medical history. She was slightly myopic, history of uncontrolled POAG, followed by her general ophthalmologist for quite a while. She presents to me in February 8th of 2012. She actually just recently told that her mom had elevated glaucoma. What's funny is about a year ago, I saw her mom and did very similar surgeries to her mom. But she's on dorzolamide, timolol, and latanoprost, and allergy to brimonidine. On February 8th of 2012, she has a pressures of 28 and 23, and glaucomatous optic neuropathies. Pertinent findings on slit lamp. She has no evidence of any secondary open angle glaucomas, no apparent angle dysgenesis, and she has mild cataracts. You can see what her discs look like in 2012. The right more cupped than the left in a classic glaucomatous manner. She has a mild nasal step on the right side. And you can see a corresponding defect and loss of the nerve fiber layer on OCT. Again, this is back in 2012. So what are our options? We could retry brimonidine, put her on oral meds, try SLT, trab tube, deep splectomy, canaloplasty. Again, this is 2012, so kind of shift your mind back to what life was like back then. You could consider an ab internal trabeculotomy, but a lot of the other glaucoma surgeries, the MIGS devices were not available, at least not in the US. And the first ever GAT we did back in October 2011. So this was literally 5 months after the very first GAT was ever performed. And so what we did was I started on max meds, put her on pilocarpine, put her on methazolamide, had her come back a couple weeks later, pressure still pretty high, and scheduled her for an isolated GAT in her right eye. And I added brimonidine while we're getting her scheduled. This is not her eye, but this is what you can see after a GAT. And initially, once we first did this surgery, we were really trying to battle with hyphemas, and we did not leave any helon in the eye. Now, based on the episcleral venous fluid wave and the amount of blood reflux, we do leave some helon in the eye. But on post-op day 1, her pressure was 10. Her vision was down because of the microhyphema. And then at 1 week, you see the layered hyphema got greater. That's not because there was more bleeding, but all the microhyphema started layering down, and then your eye is clearing it. So sometimes as the blood settles, you see the size of the layered hyphema go up, but the anterior chamber gets more quiet. Postoperative month 1, in her right eye, her pressure is still great. She's off all glaucoma drops. She's still on Pred Forte 4 times a day. Hyphema is gone. Her left eye is acting up, and we can't really. I don't want to put her on any methazolamide because I don't want the pressure in the right eye to go too low. So I put her on alpha MP in that eye. And 6 weeks out, she's doing great. She's on Pred. I add Pilo because sometimes you can get a mild, I'm calling it a steroid response after a GAT. Pilocarpine works tremendously well in that situation. 2.5 months out, her pressure is great. Her vision's going down. Her cataract's starting to get a little bit worse in that right eye. Her left eye is still not where I want it to be, but we really want to get this right eye as stable as possible before we touch her left eye. So, actually we moved forward with the cataract surgery in her right eye, standalone cataract surgery. And on post-operative day 1, her pressure spiked up to 22, put her on pilocarpine and antibiotics and steroids. 1 week out, her pressure was 13, just on Pilo twice and Pred Forte 4. I really like Pilo it's my first go-to after a GAT when the pressure goes up. Her left eye pressure is kind of going in and out of the mid to upper 20s, and she's interested in getting off drops because she's using a ton of drops in that left eye and nothing in her right eye, no glaucoma drops. So at about 3 weeks, I feel the right eye is stabilized, and we've gone through the hump. The pressure's 20/20. I think the risk is relatively low now. Her pressure's phenomenal. And so I move forward with a GAT, not a phaco GAT, just a GAT in her left eye. And this is what we did. What I did. So in her right eye, did a GAT in her right eye in March 2012, and then it ended up doing a phaco. Actually, it should be February 2013. Sorry, July 2013 was her phaco. No, I messed up. Sorry. I did a GAT in her right eye in March 2012, and then a phaco in July. This is where the mistake was. I did a GAT in her left eye in August, and then in January of 2013, I did a GAT phaco. Over 4 years, from 13 to 17, her pressure has been really well controlled in the 11 to 14 range on latanoprost and steroids once a day. In 2017, she developed a macular hole on the right eye and was scheduled for surgery. Usually what I do in all my glaucoma patients that have retina surgery, I say, come see me a week later because I know your pressure is going to be high. And in fact, it was spiked up to 32 a week after her vitrectomy and membrane peel. I added timolol and pilocarpine on the right side, and 2 weeks later, her pressure came down. And then her last visit was in November. 7.5 years after her right eye GAT and 7.25 years after her left eye. Her vision is still thankfully phenomenal. Pressures are 15 and 13 just on pilocarpine at night in the right, timolol in the morning in the right, and latanoprost in the evening in both eyes. Sustained drop in pressure on a lot fewer medications. And this is her right eye over 7 years. You can see, there's probably been some progression of the glaucomatous optic neuropathy, especially in that infratemporal quadrant. That could have been from her initial presentation of the spike, as well as probably the follow-up vitrectomy and the spike after that. Her left eye, thankfully, has stabilized and not changed. You can see this is 2012, 2013, and this is 2019, June. Any day that you don't have COVID and you're in a glaucoma clinic and you have stability like this over 7 years is a great day, which we love to see. You can see on nerve fiber layer over 7 years, it's been relatively stable after that initial loss from her initial presentation. And the same thing is true in the left eye. Initially after we got her pressures controlled, we've had quite decent stability of the nerve fiber layer over 5 years. Thoughts on this case 7 years later? Again, this was initially, we were just trying to figure out this whole GAT thing. And now, when I look back, I'm more likely to do a phaco GAT, especially in her second eye, given the fact that she developed a cataract in her right eye so quickly. I leave some Helon in the eye based on the wave and the blood reflux. That minimizes my postoperative hyphema. And sometimes you leave patients on long-term Pilo and Predforte. So let's show a GAT video. This is a paracentesis in the temporal and infranasal quadrants. This is a left eye. Putting in Myocol, I don't think it really protects me at all from hitting the lens. It just kind of makes me feel better. But putting some Helon. This is a 5-0 proline with a blunted tip. You can see right here, I cut a couple blood vessels right on my incision, and that heme is going to go into the lens. That's poor style points, and it's going to become annoying as you can see that blood creeping into it. I'm making a goniotomy with an MVR blade. This can be done, again, you can see that heme obscuring your view a little bit. With an MVR blade, this can be done with a 23 gauge needle. I come off and wash off that hemorrhage on the interface of the gonio and the cornea. You want to come as tangential as possible. And you can see that tip, that's as much of the blunted tip you want. And then as I'm feeding it, I'll look. And once you round that first 90 degrees, you're almost pretty much home free usually, unless it pops out. And then you're gonna see after about 180 degrees, after the suture is past 180 degrees and now it's going this way, when I'm pushing it this way, the resistance increases. And that's a good sign. You know you're in the right place. And then right when you give up hope, you keep passing it. As soon as you start to doubt yourself, then you sometimes will see that little bulb coming across and that blunted tip, and everything is better with the world. And then you go over the suture. If you go under, you can it kind of creates a little kink. So you go over the suture, make sure you don't grab the iris or any of that trabecular shelf. And there you have a 360 trabeculotomy through 2 paracenteses with a $4 suture. I don't use any bimanual irrigation aspiration. I just wash out the eye with a balanced salt solution, and that's all the GV coming out. And then you also, you'll see some blood reflux, which is a good sign. And this patient didn't have the most amazing wave, but you'll see, you can see she has some blood reflux. But if you kind of go in and out in fast motion, you can kind of see that blanching of the episcleral vasculature, which is evidence that you're shunting balanced salt solution into the episcleral vasculature. And we've shown through different studies that that's a good prognostic indicator. More and more papers are being done on GAT, which is nice. And I think the more and more centers that are doing GAT, the more we're going to learn about it, and the smarter we'll be on how it should be done. We're seeing this evolution in trabeculotomy, and I think GAT is the next step, and hopefully there'll be another step after that to make this even better. This is what I use for GAT. If you want to take a picture of it, these are all the instruments I use for GAT. Epsilon, again, I have no financial relationships with them, but they actually make some really good, inexpensive, high-quality tying forceps that I use now for GAT, and their service is a lot better than some of the other microsurgical instrument companies out there. This is when I do GAT, at least in the US, in mild and moderate POAG, all stages of secondary. And not in this eye stent patient or something like that where they just need they're ocular hypertensive and they need mild pressure lowering. This is for patients that have real deal disease. I think these are the best patients for GAT, mild and moderate POAG. This Avastin-induced glaucoma, the patients that are getting multiple Avastin injections that, that vehicle starts to clog up the trabecular meshwork. It's phenomenal for pseudoexfoliation and steroid-induced glaucoma, non-granulomatous uveitis, traumatic glaucoma with angle recession once the eyes calm down. Without question, the gold standard, I think, for primary congenital glaucoma and juvenile open angle glaucoma when you have a good view to the angle. And in newly diagnosed glaucoma. So when I've done this in for example, in India, in advanced eyes, their eyes haven't been abused. And a lot of countries that don't have patients that are on drops for 20, 30 years, they present with advanced glaucoma and their eyes haven't been abused by drops for so long, and their eyes and their conjunctiva behaves in a much more kind of virgin and healthy way. And those eyes, even though they have advanced glaucoma, tend to do quite well. I don't do this in patients where I don't think they have an intact outflow pathway, who can't be on hyphema precautions or taking off blood thinners, or an unstable lens, or this broad PAS in the angle. So I think in conclusion, GAT, I think, is a novel, safe, minimally invasive conjunctival sparing surgery. And our studies have shown that, and other practices have shown this as well, that over 2 years, a relatively high rate of success with a low cumulative proportion of failure and a relatively low cumulative proportion of reoperation, depending on the different groups. I'd love to see some prospective GAT trials. We're trying our best to get one of those started to see other centers do report their outcomes. I think suture GAT is equally effective than a catheter GAT, $4 compared to a $750 catheter. I think there's tremendous implications for cost-effective delivery of healthcare in the MIGS space that no one is really addressing too much. And I think when it comes to MIGS, we need to start talking about cost-effective care. This is from one of my friends from Canada. This is Canadian money, so it's kind of like monopoly money, but he really kind of looked at the different devices and kind of gave a cost per pressure lowering based on the studies out there. Really makes a case for the cost-effective nature of GAT. This is not a map of COVID. This is a map of everywhere where I think GAT is being done in over 22 countries as far as I know, and hopefully it's continuing to spread. During this time, I think we're all in very unique situations, and we're all going through this as a global society. But just random advice for all my friends and colleagues, keep staying safe, take care of yourselves and your family and your patients and your colleagues. To also take advantage of this time. I mean, I think never again, especially with us that have young kids, never we're gonna have this much time with our families, which sometimes can be trying, but usually it's a lot of fun. And don't forget to laugh and have fun. I don't know about what testing is like throughout the world, but in America right now, the best way to get tested is to cough in a rich person's face. They'll get tested, and then we'll see, you'll get your results. So that's one of my favorite statements. But we're having some fun, being outside. Nothing better than fresh air and eating as a family outside and changing things up and enjoying time with the family. It's also, I think, a unique time to be thankful. So thankful for this opportunity to speak with my colleagues and see everybody and have this conversation worldwide. And I think it's given us a new appreciation for life and our friends and our kids. And so what we do every evening when we sit down for dinner is we go around the table with our family and talk about what we're thankful for, and do our best to have patience. And I tell my wife, don't forget to laugh. I tell my wife that I'm thankful that I have someone I enjoy being with when I'm quarantined, and she's like, "Wow, that must be nice." No, so don't stop laughing and having fun and being safe. For those who wish to learn GAT, I have once the world opens up again, I have an open door policy in my operating room. Everybody's welcome to join. For the past 3 years, and we just got accepted this year as well. If there is an academy meeting this year, we have a GAT course that we teach that has a phenomenal panel of international experts to give people a nice introduction of GAT that's being done around the world. This was my last time, my only time at Kikesh. I was really just thankful. This was back when Randy was there and Samir Ahmad was there as well. And I just had such a blast there, and you guys were so welcoming and hospitable. And I really had a great time. So thank you for having me out there. And I really enjoyed it. So thank you for Dr. Ohoud and Dr. Rizwan and the committee, the CME office, for making this exchange happen. And I take any questions, but thank you all for your time and continue to be safe.
Thank you so much, Dr. Grover. I do appreciate your time. And I know, guys, you are doing a lot of GAT procedure at your center. And by the way, who inspired the other first? The GAT, the Glaucoma Associate of Texas inspired GAT, or the other way? Who came first?
Glaucoma Associates of Texas we've been around since 1982. So my senior partner, Ron Fellman, he's kind of the mastermind. He was the first one that came up with the idea of GAT, but wasn't able to do it. And then he and I did it for the very first time in October of 2012. Actually 2011, but he's a great thinker and really just a creative gentleman and a scholar, and he actually termed a lot of things that we do. He's the one that actually coined the term canaloplasty, and he sat in his office and came up with a fun name for GAT, and with the intention of it, you know, coincidentally matching the name of our practice. So
interesting. So in terms of efficacy and the outcome, how would you compare GAT to ab interno canaloplasty or ABIC?
You know, I think what we need to do, so GAT has been around for about eight years now. It's a modification of a surgery that's been around for 60 years. And the GAT data that we've published and other centers have published kind of mirrors the ab externo trabeculotomy data. If not, it's a little bit better. But ABIC, or ab interno canaloplasty, has been around. I think they started doing it about 5 years ago or so. And you know, I don't see any good data published out on ABIC. When you look back at the ab externo canaloplasty, that paper that Rick Lewis published in Journal of Cataract and Refractive Surgery, there was a small subsegment of patients that just had canaloplasty and did not have a retention suture, and those patients didn't do that well. Every data, I've not seen any data published on ABIC in the peer-reviewed literature. And so if a surgery's been around for 5 years and you don't have any published data in the peer-reviewed literature, I think that should make you take pause. You know, I think there is a role for viscodilation, and whether that you need a $750 suture catheter to do that, or if after doing a GAT, you pump up the eye and lavage the system, and that creates an additional viscodilation component. It's to be seen, but it's hard to know about ABIC because they haven't published any data in peer-reviewed literature as far as I know. And the data I have seen has been kind of more of an abstract, showing 100% success rate, which nothing in glaucoma is 100%. So, so I think if you're going to take the time and use the expense of doing a catheter, then I think it would make more sense to at least open up some of the angle. Whether you have to open up 360 or 180, I don't think there's a consensus on that. But I think the data that I've seen so far on pure viscodilation without a significant trabeculotomy is not there.
Okay, I've seen some of your surgeries on YouTube at which you've been using the microcatheter. So when would you prefer to use the microcatheter or the 5-O Prolene?
Yeah, I've switched almost extensively now to the 5-O Prolene, and some of my friends and colleagues around the world are using Prolene only. And when I've tried to teach this around the world, what's interesting is some people, I used to think the catheter was easier to teach it because you can see that blinking light. But I've actually had some people tell me that they prefer the Prolene because if you use the catheter and you kink it, you're done, and you lose that ability to pass it, as opposed to the Prolene suture is really a lot stronger and it's harder to kink. The times that I only use the catheter now are in my primary congenital glaucoma cases. So in patients where I think they are likely to have a dysgenic angle or an incompetent back wall of Schlemm's canal, and they're more likely to go in the suprachoroidal space. So my 3-month-old babies that I'm doing a GAT on, But you know, I outside of my primary congenital glaucoma, I will always go first for the suture. And I know one of my colleagues in Turkey, Zeynep Aktaş, she has done a lot of kids with the suture and has reported really good success. So if you have the luxury and the ability to spend the money on the catheter, I think it would make sense in doing a congenital glaucoma eye. But outside of that, I really have found no difference in success rates between the catheter versus the suture.
Okay, perfect. Thank you so much, Dr. Gruber. We'll just move to the next presentation. Would you please just, yeah. Okay, so our next speaker is Dr. Rizwan Malik. He's a senior consultant at King Khalid Eye Specialist Hospital, KCAS in Riyadh. He had his fellowship from Royal College of Ophthalmologists at UK, and he also has a master in clinical trials from London School of Hygiene and Tropical Medicine. And he has been awarded as the teacher of KCAS, or Teacher of the Year at KCAS for 2017 and 2019. So today, Dr. Malik is going to teach us about deep sclerectomy with circumferential trabeculotomy. Please go ahead, Dr. Malik.
You're just making sure you can hear me?
Yes.
Okay, great. So today I'm going to talk about deep sclerectomy with trabeculotomy, and this follows on nicely from Dr. Grover's talk on ab interno trabeculotomy. And I thought this would be best illustrated by discussing a patient. So I had a 23-year-old lady who came from southern Saudi Arabia. She used to fly in to see us, and she'd been diagnosed a couple of years earlier with the VKH uveitis. Unfortunately, she was under the uveitic team, and she was well controlled on systemic immunosuppression. When I saw her for the first time, she was on topical treatment. She was on Zolomol, which is like a Cosopt, used twice a day to both eyes, and Alphagan. And she was using steroids just once a day, Pred 40 to both eyes. She'd had no prior glaucoma surgery. On examination, she had visual acuities of 20/20 in each eye. Pressure was 25 in the right eye and 48 in the left eye, with around average corneal thicknesses. Anterior chambers were quiet, and she had wide open angles on gonioscopy. Her right disc looked healthy. Her left disc was advanced and cupped at about 0.9 with an inferior notch. This is her right visual field, and in fact her disc was healthy in this eye, so I'm sure she had visual field loss due to previous choroiditis, as well as previous choroiditis and retinal damage from her uveitis. In the left eye, she had very minimal visual field remaining. This is a picture of a right optic disc showing a fairly pink and healthy optic disc. In the left eye, this picture was taken about 3 months prior to presentation with me, where you can see she has an inferior notch, and she has about 0.7 cup here, so it looks like she'd progressed by the time she'd come to me. So clearly it looks like this lady needs surgery, and the variety of surgical options, we did in fact stop her topical steroid drops and put on some Diamox, but it didn't have any effect. So we could consider trabeculectomy, and we could argue that in view of her young age and advanced field loss, this would be most likely to achieve her target IOP. There are a couple of problems with trabeculectomy in this lady. Firstly, it is inflammatory, and certainly doing a PI is likely to exacerbate her uveitis for some time. even though we gave her IV pulsed methylprednisolone for 3 days beforehand. But the major issue was that she lived far away and she couldn't come in for appointments very frequently. And so suture lysis or removal of releasable sutures post-trabeculectomy was going to be a bit of a problem. So could we consider deep sclerectomy, which has got a wide open angle? So that's an option. That's likely to get her IOP to mid-teens or high teens long term, and it's probably more practical for her because it doesn't require much post-op follow-up. And it's possible that if we combine this with another procedure, trabeculotomy, with viscodilating the canal, that we might be able to achieve lower pressures. And that's certainly been my experience in a few of these patients. I wouldn't consider a valved glaucoma drainage device at this time. If she had active uveitis, I probably wouldn't go to a filter. I'd probably put in an Ahmed valve initially. But as her uveitis was well controlled, I would leave a valve drainage device for later on if she needed it. So let's go to the surgery. And this surgery is actually being done by fellows. Mohammed Dibaju graduated from our fellowship program. And we're doing a conjunctivorectomy here. And you can see she has very thick tenons. We make a superficial flap around 5 by 5 millimeters initially. And I dissect this with a half thickness super sharp blade and then a crescent blade, as is the standard technique we were taught at Moorfields. And the advantage of this technique is if there's some bleeding, then it doesn't affect things too much. And you have to get quite anterior here, about 2 millimeters into the cornea, which will facilitate exposure of Schlemm's canal later. And initially, the few cases I did, I probably didn't get anterior enough. Here we're putting our mitomycin sponges in, and now I've switched to actually using one large sponge rather than a few sponges, as sometimes you can find one difficult to retrieve. And after this has been irrigated, we can then continue our anterior dissection. You can see the color of the sclera changing here. And then start our deeper dissection with a 4 by 4 millimeter scleral flap. And when you start this flap, it's actually quite important to start deep because you have to be quite deep when you get anterior near Schlemm's canal to expose the canal. If you don't start deep, it's more difficult to dissect deeper as you go on, but you can always get more superficial more easily. So now we're making a paracentesis, and this is not essential. If you feel the pressure is not very high in the eye, you don't need to do one, but in this case we did one. And we can see we're getting to the area of the Schlemm's canal. And this is an essential step, peeling of the Schlemm's canal. And once we do this step, you can see we're beginning to see your percolation of aqueous. And just using a blunt cannula here to prod Schlemm's canal, make sure we're in the right place. And once we've done this, here we're using an eye-track catheter, similar to what Dr. Grover described. And here we're using an ab externo. So the advantage of this is it has a blinking light. So when you switch off the room lights, you can make sure you're in the canal and not in the suprachoroidal space. And in this case, we are fortunate enough to get around 360 degrees. It's not always possible. And then as we're withdrawing the tip, withdrawing the catheter, we're now viscodilating the canal. And then we're completing our deep sclerectomy by amputating the deep flap and putting the scleral flap sutures. And these don't have to be very tight. I usually place an air bubble, or sometimes in children a gas bubble, inside the anterior chamber. And that helps keep the AC deep post-operatively and also get the right tension on those scleral flap sutures. And we close conjunctiva with a 9-0 Vicryl Vas needle. So in the post-operative course, 1 week post-op, the vision for this lady in the left eye was 20/40. She had a deep, quiet anterior chamber. She was still on systemic immunosuppression. Her intraocular pressure was 7 without any choroidals. And you can see from the picture there that her eye looks pretty quiet 1 week post-op, which would be unusual if she had a trabeculectomy. And recently she completed a 1-year post-op follow-up, vision's back up to 20/20, and she has an intraocular pressure of 13 on 1 drop. So in summary, combining deep sclerectomy with trabeculotomy may achieve a slightly lower intraocular pressure than deep sclerectomy alone. I don't have a large amount of evidence for this, but certainly from the few cases that I've done, it seems to work well. And it's a useful procedure when trabeculectomy is not ideal in terms of suboptimal follow-up. It certainly seems to work well in certain cases of open-angle glaucoma. I found young patients with juvenile open-angle glaucoma or steroid-induced glaucoma seem to do quite well, and the milder cases of children with primary congenital glaucoma also seem to do quite well. Thank you very much.
Thank you so much, Dr. Malik. Very nice presentation, very interesting case. So which one do you think is making the more, let me say, action? Is it the DS or the trabeculotomy?
That's really anyone's guess, really, to be honest. You know, usually with a deep sclerectomy, I find that the pressure after a year is around mid to high teens. And with combining the procedures, often you can get to the lower teens. So that would suggest to me that maybe both are doing something.
Okay, great. Thank you so much. So we'll go to the last presentation. Last but not least, we have Dr. Conrad Chardil. He's a glaucoma consultant at King Khalid Eye Specialist Hospital, KCASH, and he had a fellowship in glaucoma, retina, and anterior segment. And before joining KCASH, he was the head of glaucoma and anterior segment, ocular trauma and neuro-ophthalmology section at University Hospital of Torrevieja, Alicante, Spain. Buenas tardes, Dr. Chardil. How are you?
Buenas tardes, Dr. Ohoud.
Okay. Who said Spanish is difficult? It's not difficult.
Yeah, well, and anyways, there is a lot of my Spanish colleagues right now connected, and if you allow me, I just want to say a couple of words. Estoy con ustedes, los llevo en mi corazón y mucho ánimo. And back now to the English. Thank you, Dr. Ohoud, for inviting me for this presentation. Let me see if I'm able to share the screen. I guess that everyone has the same problem, so I don't feel that bad now. Desktop should be this. Can everybody see my slides?
Yes.
Okay, great. Then I think I got it. So basically, as you can see, we had a lot of cases of Voco-Yanagi-Harada syndrome, it seems. What I'm going to talk is about a case of a male patient, 24 years old, that came from Najran, all right? That is about 1,000 kilometers away. It was referred with a diagnosis of panuveitis for further management in our center. King Khalid Eye Specialist Hospital, for those who doesn't know, is the main center for eye care of all the kingdom. So when all the complicated cases are there, cannot be treated in the region, they are sent to our hospital. So the main complaint of this gentleman is redness and blurred vision. He arrived in September 2018, complaining that most of the signs and symptoms started about 5 years back. And he has, in 2017, a phacoemulsification in the left eye. And he referred that only noticed an improvement of the vision for 3 months, and then it was a drop of vision again. At the time of arrival at our center, there is no medical treatment. And Uveitis team is the one that takes care of the patient initially. And they make a full exploration and found out that he has the lips discoloration, tinnitus, and some neurological other symptoms. At that time of presentation, the vision in the right eye is 2200. The vision in the left eye is hand motion. And the pressure were 13 in the right eye and 33 in the left eye. That's why glaucoma on call is called. And these are the findings that the patient has in the anterior segment. Mainly the most significant is that it has some fine keratic precipitates and some inflammatory reaction in anterior chamber. Right eye, it's described like synechia and very non-reactive pupil, very small. In the left eye, the pupil also is not responded, but there is a cataract been removed, so there is an IOL well center. And it's the only eye that can be explored, the retina and the optic nerve. Well, this was the diagnosis that he has at that moment as a not very reactive panuveitis, but they start to work out to try to find possible causes. At that time, he doesn't have the diagnosis of Voco-Yanagi-Harada. The second diagnosis was the cataract in the right eye and the high IOP due to a secondary closed angle glaucoma. In our center, as a initial treatment for high intraocular pressure, it's the stat medication. Stat medication is full topical medication plus Diamox, and full medication means also prostaglandins analog. He start also topical steroids, and the appointments for the glaucoma division and uveitis for control has been given. So at the second visit in uveitis, the pressure is well controlled. It was 33 and went down with the full medication, as I said, even with the bimatoprost. It went down to 18. There is no description of increasing of the inflammatory reaction inside of the anterior chamber. As you can see, the vision improved in the left eye. It decreased in the right eye. And what I suggest in that moment was discontinuous the bimatoprost and also the Diamox due to the good control of the pressure, and they start the immunosuppression. So by the time it comes to the glaucoma division, it was 1.5 months after. The pressure is still good, well controlled with Sholamol, as Dr. Malik referred, is a fixed combination of dorzolamide and timolol plus alpha-GAN. So the pressure in the left eye is well controlled. Right eye start to increase slightly, and vision in both eyes remains in 2160. These are the first anterior segment pictures we got. Right eye has a, well, basically, I don't know if you can see my mouth moving, but there is only this area that seems to be open in the right eye. The rest is almost 280 degrees synechia. In the other eye, the pupil is not, of course, is not reactive. You can see that in the anterior face of the lens, there is like an inflammatory membrane. There is also anterior synechias, and what it seems, it was an attempt to do iridotomies. And as was mentioned previously, iridotomies in these kind of cases increases the inflammatory response. So probably that's why in the areas where the iridotomies are done or attempted to be done, it's where the synechias are worse. As you can see in the left eye, this is what I meant. So there is basically a close angle in the periphery in both sectors, especially where the iridotomies were attended to do. There is almost iris bombé. And these are the UVM images. You can see that it's attached. What it surprised is that even with only 3 topical medication, the pressure, it's well controlled. So in somewhere, even if I don't see it by the images, in somewhere there is a filtration in this eye. And this is the imagine of the right eye on the UVM. And what I don't like is you can see that there is this very thick membrane right over the anterior face of the lens that almost has the same thickness that the iris. You cannot see where are the difference, all right? It's only can be seen the pictures of the left eye, and according to the images, we can well, you can see that the ocular fundus is basically the hallmark of the chronic uveitis stage of the Vogt-Koyanagi-Harada, which is the sunset glow fundus. It also has this foci of hypopigmentation in the periphery. So we attempt to do a B scan in order to evaluate the right eye. We were not able really to look through that thick membrane into the optic nerve and evaluate the capping. And the description here is basically mild to moderate vitreous opacities in both eyes, thick macular area, both eyes. And what I'm missing is mainly the information that I want. What is the disc capping? So with this, where are we? Well, basically, as you know, Vogt-Koyanagi-Harada has 4 stages according to the workshop of Vogt-Koyanagi-Harada group in 2001. And I can imagine that the first eye, left eye, the phacoemulsification was done during the acute uveitis phase between the acute uveitis and the chronic uveitis. Why? Because of the intense inflammatory reaction. On the other hand, it could be related to the cataract surgery, or it could be also related to the attempts of iridotomy, but there is no report. So I don't exactly know what was first, if they attempt to do the iridotomies, or the iridotomies were trying to were attempted after the phacoemulsification. And here is where I am. I'm between somewhere in the chronic uveitis and the chronic recurrent phase, in which we have the sunset glow fundus, the periphery hypopigmentation, and chronic recurrent stage is one of the stages in Vogt-Koyanagi-Harada that we can have more risk of having anterior uveitis. So at this point, it's my questions were what to do. Shall I remove the synechias and the cataract of the right eye, or shall I go for a glaucoma procedure in the left eye? It's up to everyone. So my options were, I'm gonna choose to go for the phacoemulsification, thinking that the risk of also having a pupillary occlusion, and for me, and the uveitis department was very important to have also an evaluation of the posterior pole. So here is the video, and what I first find is that I'm not able to get under that synechia. It's impossible. So I have to cut it with the NVR 20 gauge. I'm working through 2 paracenteses. Once I make the hole, I'm trying to make the dissection with the viscoelastic as ordinary do, and you can see how the traction over the iris. So there is such a thick fibrous membrane right behind the iris that doesn't allow the movement of the iris a lot, and I need to remove it with the retina forceps, and also doing some contra pressure using a secondary instrument like a Kluger hook that I'm having in the left hand. And until I'm able to remove such a fibrosis under the iris, as you can see here, it's basically all over almost 360 degrees behind. Once it's removed, well, the iris, of course, will do not move freely, and I don't like the size of that pupil. So I decided to put the 6.25 Maljugenrin in order to keep the proper distance. What I didn't want to have, even if it looks like a very soft cataract, what I didn't want to have is any problem. And I'm trying to avoid most of the manipulation over the iris, because I know that all the manipulations I will do, it will pay the price later on as increasing the inflammation. But once we got this point, really the cataract went smooth. And the only thing that sometimes I consider is, in this case, well, putting a 3 pieces lens, because I don't want that the optics touch the iris too much, but in this case was a single piece. And at the end of the surgery, basically, steroids treatment, subconjunctival, and that was the surgery. So 1 month post-op, the vision is 20/80, that improved to 20/60, and the pressure remains in the right eye 15 and in the left eye 18 with the 3 medications. And as you can see, well, it looks quite clear and easy. And it was the first time we were able to take the pictures and take a look at the posterior pole in the right eye. And as you can see, basically both eyes are the same, but this cupping in the left eye, it's really advanced. The right eye, it's the good eye. Both has the damage in the macula that are also described in the, and were important to be observed. And that's why the need of removing that cataract. So, well, this is my team. This is my family now since the last 3 years, fellows and consultants that treat me like I were at home. Of course, I miss my colleagues in Spain, but these guys here make me feel like in home too. So I guess you want to know how the story ended. This patient has 1 year that I did the surgery in the right eye, and it has controls at the uveitis division and in glaucoma. Right now, left eye is on Simbrinza and Ganfor, and no treatment in the right eye. And the vision is 20/60 with the best correction and 2300 in the left eye. Pressure in right eye was 14 when he came in December, and in the left eye it came up to 50. So at the end, this gentleman finished with the tube implanted in sulcus in the left eye, very recent. So here is where we stop this story. Thank you very much. I will set only this as a summary. I think that when we have cases of uveitis, it must be treated. And here is probably the success of this case is that it was managed very good by the uveitis department, and controlling and cooling down this inflammatory process is what it makes the warranty of success in the cataract surgery. Important thing is, before going into the OR, have everything studied and have the plan well done. And the full clinical history is really vital. Thank you very much.
Thank you so much, Dr. Chargil. So did you start this patient on systemic steroids either before or after the surgery? And what's your protocol usually in such cases?
Well, we were working together with the uveitis clinic. So what we did, they start immunosuppression and they start steroid, systemic steroid. Yeah, I think it's in one of the slides it was mentioned. And, you know, as the protocol now, when we are going to do any uveitis case surgery, the patient must be admitted a few days before, so the uveitis clinic can start treatment, systemic treatment. Like, I think it's 4 days before the surgery, they have to start the systemic medication. And they really are very good in this. They are really having a very close control of these patients, and that is probably the reason why this cataract has an evolution like a normal cataract.
Thank you so much, Dr. Chargil. So can we have all the panelists on the cam, please? Can you have your cams on, please, all the panelists?
I'm trying to get
Any
out.
comments?
No comments except to say thank you for having me. And as I was texting you, just to say, inshallah, everybody stay safe. And this is great. We get to connect with each other, and thanks for having me for sure.
Thank you all for joining us. And it has been an absolute honor to have all of us, all of you with us today. And I'm sure that you agree that it was a very enriching and enlightening conference. And I hope that we can do more of these webinars in the future, despite what we are going through these days. So thank you so much. And thank you to all the attendees for being with us beyond the scheduled time. And sorry for those questions that we couldn't answer. But anyhow, I'm sure you can reach those speakers on their emails if you have specific questions. Thank you. I need a promise from each one of you that we can make more of these webinars and conferences.
Inshallah.
Yes. Yeah. Thank you so much. Please stay safe all.
Thanks.
Thank you. Thank you. Take care.
Yeah, bye, everybody. Bye. Stay safe.
Bye, everyone. Thank you. Salam.
Yeah.
Assalamu alaikum.